Thank you, Dr. Cornelius. I'll briefly introduce the topic for today. TBI, talk about applied neurophysiology briefly, just to stimulate the discussion. Our outline today will look at cerebral blood flow, intracranial pressure, and a reminder about the blood-brain barrier. The first slide, this is just a reminder of the blood supply to the brain. And I would implore us to also review the blood supply. That's both the supply and the drainage to the spinal cord. This is just to remind us about the arterial and the venous blood supply to the brain. Deep into cerebral blood flow. Basically, the brain receives about 15% of the cardiac output at resting state. That's about 750 mils per minute. The brain is about 1.5 grams in an adult, and it comes to about an average of 500 mils per minute per 100 grams of brain parenchyma. Blood supply to the brain is varied, regional, depending on the region, but on average, the white matter receives about 20 mils per minute per 100 grams, with the gray matter receiving about 80. The average globally is what we normally quote as 50 mils per minute. Cerebral blood flow is important for brain function, supply of nutrients, oxygen, and then issues around temperature, pH. So when you have a reduced cerebral blood flow below 2025, that's when you get features of cerebral impairment. And below 10 is when you have irreversible neuronal injury. I would want to remind us that there are many factors that affect cerebral blood flow, and it can range from the 50 we have talked about up to 300 mils per minute per gram, depending on the condition. These are some of the factors that will affect the cerebral blood flow: autoregulation, metabolic activity, the blood gases, of course, cardiac outputs, sympathetic activity, and of course, the drugs that we may give, the antihypertensives and the anesthesia drugs that we use. I will go through some of the important factors here as a preamble, as a reminder to the discussion ahead. The metabolic activity of the brain, like I said, there's regional blood flow, and it's linked to the metabolic activity of the brain. This is usually called the flow metabolic coupling. And as we have said in the previous slide, the gray matter receives more blood supply purely because it is more metabolically active than the white matter. The brain has no oxygen reserve and consumes 20% of the total body oxygen that we breathe in. And of course, that is very important for ATP production. The primary substrate for ATP production in the brain is glucose. And as we are aware, in times of starvation, the brain can divert and use ketones, acetoacetate and other ketones. It is important to note that whereas glucose is an important molecule for ATP production in the brain, both hypoglycemia and hyperglycemia are deleterious. They are harmful, as we shall see in the discussion around the traumatic brain injury. The other factor I would like to quickly remind us about is the autoregulation. Autoregulation basically refers to a constant cerebral blood flow to the brain within certain limits of perfusion pressure. Perfusion pressure is not the same as MAP, and I would like to remind us that cerebral perfusion pressure is the difference between the mean arterial pressure and intracranial pressure that we shall talk about. So basically, this is the pressure that permits cerebral blood flow. The other factor that affects cerebral blood pressure, cerebral perfusion pressure, is the central venous pressure, return of blood into the mediastinum. So anything that increases the central venous pressure, within the thoracic cavity, can have a bearing on the cerebral perfusion pressure. The autoregulatory limits, like I've said, that there's a range within which we maintain the cerebral perfusion pressure with the cerebral blood flow. And like I said, around 50 mils per 100 grams per minute. The physiological range is 50 to 150 millimeters of mercury. That is in a normal, in a healthy adult. There are conditions that disturb this regulatory mechanism and cause a shift. The well-known one is chronic hypertension, causes changes in the vascular structure and the tone, and shifts this regulatory mechanism to the right. There are other factors like anesthetic gases that we shall come across that affect this, but the physiological one that does this is chronic hypertension. Below there is a graph that tries to depict the vascular tone. I hope it's a clear across this entire range of the cerebral perfusion pressure. Before less than 50 millimeters of mercury, we have the vessels dilated, the cerebral vessels, and we have maximum. We have collapse. Where the cerebral perfusion pressure is low and the vessels are dilated. Within this normal range, the central mechanism to maintaining cerebral blood flow and the cerebral blood flow around 50 mils per minute per 100 grams is around change in the vascular diameter for the different cerebral perfusion pressure. As the perfusion pressure increases, there's a decrease in the diameter. There's a vasoconstriction within the cerebral vessels. Key to note that this cerebral autoregulation is mediated by three mechanisms. There's a myogenic, neurogenic, and of course the metabolic link that we have talked about, the metabolic blood flow couple link. So outside this regulatory limit for cerebral perfusion pressures above 150, these mechanisms are exhausted, and then the vessels vasodilate in response to the forceful pressure. So we have increased blood flow beyond 150 millimeters of mercury due to the very high pressures that will lead to forceful vasodilatation. The other factor that we'll discuss in approach to a patient that we are treating for intracranial hypertension is in regards to cerebral blood flow is the blood gases. That is the arterial concentration of carbon dioxide and that of oxygen. The key here is carbon dioxide between 20, as you can see on that graph, depicting that there's a linear relationship between cerebral blood flow and the partial pressure of carbon dioxide within the arterial blood. That is between 20 and 80 millimeters of mercury. And the relationship is like I've said, it's linear. So for every change in the partial pressure of carbon dioxide, there is a similar change in the blood flow. Basically, 1 millimeter increase of mercury is correspond to about 1 milliliter increase in blood flow. That's about 2 to 3% of cerebral blood flow. It is known that we can use the partial pressure of carbon dioxide to really manage ICP, as we shall see ahead. When you cause a hypocapnia, you can reduce the cerebral perfusion pressure, reduce the cerebral blood flow, and then consequently reduce ICP. But the effect of that is, although it's immediate, the effect is short-lived, and the reason given is there's a compensatory change in the bicarbonate concentration in the CSF. Whereas it's the carbon dioxide that we are targeting, the partial pressure of carbon dioxide, the actual mechanism control of cerebral blood flow is around the pH of the blood and of the CSF. So the buffer bicarbonate can compensate the pH changes. That's why this effect is short-lived. Oxygen can also, the partial pressure of oxygen in blood can also affect this response, but suffice to note that it only does so at partial pressures below 50 millimeters of mercury. Basically, as you can see that curve, the partial pressure of oxygen, it really has no bearing on the cerebral blood flow unless the partial pressure has gone below 50. And the response is a compensatory increase in cerebral blood flow, so as to increase the oxygen delivery. I think we shall go to the volatile anesthetics. The key principle here for volatile anesthetics is they alter the metabolism cerebral blood flow coupling, whereas an increase in cerebral metabolic activity is expected to increase cerebral blood flow, and a decrease in activity is expected to decrease cerebral blood flow. The volatile anesthetics decrease the metabolic activity of the brain, the regional metabolic activity, but then lead to a vasodilatation of the cerebral vessels, and it's a dose-dependent relationship. So whereas the reduced metabolic rate will favor a reduction in cerebral blood flow, but then we have the vasodilatory effect of the volatile anesthetics. This can be mitigated by prior hyperventilation. Like I said previously, hyperventilation reduces the partial pressure of carbon dioxide, and that leads to causes a pH change in the CSF and the blood, leading to a reduction in what? An increase in vasotone and the reduction in cerebral vasodiameter with a reduction in cerebral blood flow. The graph here shows the effects of MAP, sevoflurane, across that graph of cerebral perfusion pressure affects blood flow. So in someone who's not yet anesthetized, we have that curve that we have already looked at between 50 and 150. You have the autoregulatory mechanisms in play. But as you increase the concentration of the anesthetic gases, they have a bearing on the autoregulatory mechanism. It's a bit preserved at a mark of 0.1, but beyond the mark of 1, the autoregulatory mechanism that governs cerebral blood flow is overpowered. So that's what I was saying, that volatile anesthetics, just like hypertension, affect our autoregulatory mechanism. Beyond the mark of 1, that autoregulatory mechanism of cerebral blood flow is lost. This is just a summary of the effects of the various anesthetic agents on cerebral blood flow, cerebral metabolic rate, cerebral blood volume, and ICP. And this can guide our choice of agent, whether in ICU or in theater. The first 5 are the volatile anesthetics that we have been talking about, and all of them lead to a decrease in the cerebral metabolic activity, like I had said. And all of them lead to a slight increase to cerebral blood flow due to the vasodilation effect, vasodilation of the vessels. But the biggest culprit here, as you can see, is halothane. So for cases that have where you do not want to increase the cerebral blood flow, increased intracranial pressure, the best advice is to avoid halothane if you are thinking about using a volatile agent. Minimal effects from nitrous oxide, as you can see. And of course, as you can see, halothane decreases the cerebral metabolic activity, but the increase in the cerebral blood flow is profound. So is the increase in intracranial pressure. At the lower half of that table looks at the The IV agents, barbiturates, etomidate, propofol, benzodiazepines. You can see all have a decreased, I would say all, putting ketamine on the side in the parking lot. Barbiturates, etomidate, propofol, and benzodiazepines have a decreased effect on the cerebral metabolic rate, and also decrease the cerebral blood flow. Ketamine. Ketamine has no effect on the cerebral metabolic rate. Reason being, it has a regional, the reason was it has a regional variation in cerebral metabolic rate, but globally, when you look at the brain as a whole, it has a minimal effect on the metabolic activity of the brain. But notably, ketamine increases the cerebral blood flow, and consequently, as you can see, it increases ICP. The opioids have no effect on the cerebral metabolic rate and the cerebral blood flow, so have no effect on ICP. So in the choice of anesthetic agents, in terms of safety for a patient with ICP, it's been shown that TIVA, total intravenous anesthesia, would be the best, probably using propofol. But in case you need to induce a coma and have a profound effect on a reduction on ICP, then barbiturates would have to be considered for that purpose. Like I said, opioids have really no effect on cerebral metabolic activity, cerebral blood flow, or ICP. A question around neuromuscular blockade. We know SARCs causes fasciculations, and there's been evidence that those can cause a slight increase in ICP. Neuromuscular, the non-depolarizing agents do not have an effect, but might have an indirect one if there is an issue of histamine being released that can cause vasodilation or ganglion block. So I would want to probably, as we will go into the discussion, given that SARCs causes a slight increase in ICP fasciculations, would you use it during intubation, or would go for the non-depolarizing? It's something that probably can facilitate discussion later on. A mention about the blood-brain barrier. This is a physiological and anatomical barrier separation between the brain, the CNS, and the blood. Basically, the role is to separate the two compartments, and so that we have to protect the brain from extracellular components. So as we know, the blood and the CSF have different concentrations of the ions and metabolites. So the function of the blood-brain barrier is to control passage of substrates between the blood and the brain, and thereby control CNS function. Key to this, what I wanted to bring out is the selective permeability of the various molecules, given that molecules cross the blood-brain barrier by various means. It's a lipid bilayer. Once the basement membrane is 1 cell thick, and so some agents cross by diffusion. Water crosses freely following the concentration gradient, following the ions. Carbon dioxide, oxygen, and lipid soluble most agents, also the volatile anesthetics and opiates cross freely. There are some agents like glucose, amino acids that are transported actively into the brain to provide substrates for ATP. And of course, bigger molecules like albumin and a number of the drugs that we give cannot get in because of the size. I would implore members, the other functions of the blood-brain barrier that are protective. The astrocytes can metabolize agents that go through the blood-brain barrier, so that to maintain the hemostasis. So there are other functions beyond selective permeability of the blood-brain barrier that I've not talked about, but in relation to this discussion, I picked out the diffusion, the selective permeability function in relation to choice of our drugs and administration, route of administration, either intrathecal or intravenous, if we consider that there is this barrier that affects transfer across that membrane. The last bit I would want to talk about the neurophysiology relevant to today's discussion is the issue of CSF production and intracranial pressure. Basically, we are aware that CSF is produced within the ventricles, most of the lateral ventricle by the choroid plexus, and then traverses to the third and later to the fourth ventricle, and then bathes the rest of the brain and the spinal cord, and is absorbed by the arachnoid villi within the venous sinuses, as you can note there on the diagram. About 500 ml is produced per day. The volume of CSF is about 150, and about 500 is formed per day. So that means 500 has to be reabsorbed daily to maintain the volume at 150. The mechanism is active secretion. What is known is sodium. Sodium is secreted against the chloride concentration gradient, and waters follow suit. So that we form a CSF, and there's also selective ultrafiltration of the plasma. The discussion around CSF is important when you're discussing intracranial pressure. As we are aware, the cranium is a rigid structure, and also after the sutures are closed. And as stated by the Monro-Kelly doctrine, the cranium contains, I would call them 3 components. Though some people call them compartments: the brain, the CSF, and the blood. And being a rigid compartment or fixed volume, an increase in one component would be compensated by a decrease in another. So if we have intracranial volume increasing, either a brain or blood or a mass, then one of the other components has to decrease to maintain a fixed volume. It is known that CSF volume reduces fast, followed by cerebral blood volume. Firstly, the venous, then the arterial blood volume, and lastly, of course, the brain compression has its effects, but that's if the compensatory options fail. If those fail, we have an increase in intracranial pressure. The source that I used, the normal intracranial pressure, is usually below 10, but the range is about 10 to below 15, 10 to 15. The source decided mentioned 10, but I've seen other sources that talk about 10 to 15. It is known that if you cough, your intracranial pressure will increase for a moment. So the definition of an increased ICP is actually a sustained increase in intracranial pressure beyond 15 millimeters of mercury. So it's important to mention that this has to be sustained, because there are other maneuvers that can temporarily increase intracranial pressure. Basically, on the right is a graph that was trying to depict this Monro-Kelly doctrine that I explained, showing that an increase in intracranial mass, intracranial volume, maybe by a space occupying region, will lead to a decrease in volume of the CSF. And if the compensatory mechanisms are exhausted, then you have an increase in pressure. And an increase in pressure, as you can see, will cause ischemia and coning and loss of gyri. The key features that you'll see on your CT scan. If it's one-sided, then you'll have midline shifts and the like. And then the signs of increased ICP clinically, if a patient is probably conscious, they will have nausea, vomiting, severe headache, and then they will lose consciousness. Then The ultimate is the Cushing's triad that depicts impending coning at the brainstem. Basically, three features: bradycardia, hypertension with a. I need to correct whether it's a increased or I think with the increased pulse pressure. I'll need to check that up, and then decreased respiratory rates. Basically, impending coning at the brainstem. I would want to summarize this preamble by highlighting a few issues around approach to management of a patient with increased ICP. Basically, like we have said in the previous slide, the intracranial pressure, you consider the brain, the CSF, blood volume. And so approach to a patient with increased ICP can follow those lines. In case increased cerebral edema is contributing to increased ICP, we have modalities that can try to reduce that. Basically, osmotherapy using either hypertonic saline or mannitol. We can combine that with diuresis. We can increase cerebral edema can be caused by can be secondary due to ischemia and reperfusion injury. So it's also important to prevent ischemia in these patients, especially post-stroke patients. And of course, if there's a space-occupying lesion that is contributing to the edema, dexamethasone steroids have been shown to contribute to that reduction. That's the approach looking at the brain. We can also try to reduce ICP looking at reducing the CSF volume. So we can drain the CSF, mostly in people where the CSF is a contributory factor in obstructive or communicating hydrocephalus. This CSF can be given an alternative route for drainage. We can support CNS drainage by patient positioning head of bed at about 30 to 45 degrees, basically, to use gravity to support CSF translocation out of the intracranial cavity. And of course, reduce CSF production by using pharmacological agents. The other compartment we can look at is blood. We can reduce the cerebral blood flow, basically affecting the cerebral blood volume. And we talked about metabolism and flow coupling, so we can reduce the cerebral metabolic rate. We have talked about the drugs that we can use, but also here important to note is the issue of temperature. We need to make sure the patient is normothermic or slightly less than, can I say slightly lower than the normal temperature, basically trying to reduce the cerebral metabolic rate and reduce cerebral blood flow. Hyperventilation, like I talked about, and carbon dioxide and how it affects cerebral blood flow. And of course, avoiding seizure activity that increases cerebral oxygen demand and hence cerebral blood flow. And any drugs that we need to avoid cerebral vasodilatation. Key to this is avoiding things like ketamine. They are antihypertensives, most so the nitroglycerin, the ones that lead to vasodilatation. They have also been shown to actually increase cerebral blood flow. I didn't include a slide on that, but we can also look up antihypertensives that we use and that lead to vasodilatation. So key to this is using maybe beta blockers to manage your hypertension so that you don't cause cerebral vasodilatation. And finally, if all these mechanisms fail to reduce cerebral or intracranial volume, the last resort is to increase the intracranial volume by a decompressive, I would say increase, but basically releasing the pressure by doing a decompressive craniotomy. And that's when you call in the neurosurgeons. Briefly, this is what I had as a preamble to applied neurophysiology as our introduction to the discussion to traumatic brain injury. Thank you, Dr. Cornelius.
All right, thank you very much, Dr. Isaiah. So if anyone has any question, please raise your hand and you can ask Dr. Isaiah. I think in the meantime, from the presentation that has been made, there are a couple of take homes that we can gather from it. Isaiah has really delved into the physiological aspects of the brain and looking at the supply, the demand, and the factors that determine that. And I think it's extremely important that this is the foundation of our discussion and understanding of the interventions and their impact. So looking back to the presentation, I think there are some key aspects that I picked out that would be quite important for us to remember. So the first one is the brain, of course, needs blood supply, but mostly it also needs oxygen. And Isaiah clearly mentioned that we need to have it has a very little to no oxygen reserve, which means it is highly susceptible to hypoxemia. And so you want to avoid hypoxia to the brain as much as you can. So that is the first take home. It's important to maintain oxygen supply to the brain at all costs because it has little to no oxygen reserves compared to other organs. So I've just seen a question come in, Dr. Isaiah. Which technique can I do to ensure hyperventilation in the patient? I think this is going to be covered as we go through this discussion. So William, please hang in there and bear with us. So I think that's the first most important point. The second important point from Isaiah is that oxygen delivery will depend on the cerebral blood flow. The cerebral blood flow is dependent on the cerebral perfusion pressure, and he mentioned that during the time when he was talking about the cerebral perfusion pressure being equal to the mean arterial pressure minus the ICP. But oxygen delivery is also dependent on the oxygen content of arterial blood, and we have to remember that the oxygen content of arterial blood is dependent on number one, the hemoglobin concentration of the patient, as well as the saturation of oxygen of the hemoglobin. So you have to make sure that all those are appropriately well covered to make sure that you deliver oxygen to the patient. And so the other aspect that I took away from this presentation that I think will be very important is that cerebral blood flow is more or less under the control of the cerebral autoregulation. And cerebral autoregulation within a particular cerebral perfusion pressure will be autoregulated. In other words, the vessels will be adjusted to allow either more flow to the brain or less flow to the brain tissue, depending on where the cerebral perfusion pressure is. But I think the formula that is shared with us with cerebral perfusion pressure equaling to mean arterial pressure minus the ICP is extremely important, because at this point, we also have to look at if you have a good blood pressure versus a lower ICP, it means that your cerebral perfusion pressure is good. And so you're having perfusion to the brain, but perfusion to the brain does not always mean that oxygen delivery is actually adequate. And that's why the oxygen content of arterial blood is also very important. And then he highlighted the mechanisms that will affect cerebral blood flow. And he mentions those to be three. I think I will add on a fourth one. Isaiah, if you bear with me, I'll add on a fourth one. So I think you mentioned myogenic, metabolic, and you mentioned which other one? Isaiah? Hello, Isaiah, are you still there?
Neurogenic.
And neurogenic. Okay, so I will also add on endothelial. And I think these are the mechanisms that we have to understand because the factors that affect those mechanisms will affect cerebral blood flow. So myogenic is really to do with the blood vessels themselves, the anatomical expansion of the blood vessels, or you can say the transmural pressure that affects the blood vessels. And then, of course, neurogenic is really to do with the nerves and the release of either vasodilators, which could be acetylcholine or nitric oxide, or they may release vasoconstrictors like serotonin, for example. And then endothelial, again, endothelium in our bodies, it can release vasodilators like nitric oxide, and it may release vasoconstrictors like endothelin. So these are all factors. And metabolic is really to do with the carbon dioxide. And Isaiah elucidated that very well. And it's important to understand the mechanisms because those mechanisms are affected by certain physiological factors that are under our control, and we can use those to be able to allow cerebral blood flow to be maintained to the brain, and therefore allow oxygen delivery to the brain. I think the other aspect that I'll open up for discussion will be dexamethasone and raising intracranial pressure, but that will be after the case presentation. Isaiah, if you'll bear with us, let's have that after the case presentation. And then, of course, finally, the Monro-Kelly doctrine is extremely important when we are discussing severe traumatic brain injury, and in light of raising intracranial pressure, basically the basic understanding of it for those of you who have just had it for your first time, Monro-Kelly is simply telling you the cranium is a cavity that is poorly compliant to any rises in volume. And so rises in volume are going to, it can dramatically increase rises in pressure, and that could significantly compromise not just blood flow to the brain, but including the oxygen delivery to the brain will be affected. If there are any questions to Isaiah, please feel free to unmute yourself or raise your hand, and I'll unmute you so that you can ask him directly, or you can share it in the chat. So far, I think there are, the question earlier on hyperventilation is answered. The next question was how to approach patients that develop hypertension after head injury. Isaiah, why do patients who have head injury develop hypertension at the same time? Stella, maybe, I do not know if the question is they develop head injury 1 year after head injury, or they develop, rather develop hypertension 1 year after head injury, or develop hypertension immediately after head injury. Would you, let me perhaps allow you to unmute yourself so that you can be able to answer that question. Give me a second. Okay. Please, Stella Namugani, please unmute yourself and put your question in context so that we can understand where you're coming from with that. And then Isaiah, yes.
Okay, good evening, everyone.
Good
And
evening.
the question is getting a patient of head injury, and the next thing you see, they're having high blood pressure, but previously the report not have been having high blood pressure, and realize you get high blood pressures of, let me say, diastolic of 100 to 110, which you can't just ignore.
Excellent question. Isaiah, please tell us about the physiology of hypertension in a patient who has severe head injury. Please tell us about that. Thank you.
Thank you, Stella, for the question. But what is known that in patients who have severe head injury, going back to the Monro-Kelly principle, and you have increased intracranial volume, that has a bearing on cerebral blood flow by if it increases the mean the ICP. We say the cerebral perfusion pressure is equal to mean arterial pressure minus ICP in this case due to the head injury. So it's known that increase in ICP will decrease the cerebral perfusion pressure, and then you'll have global or regional ischemia. What I came across, what I know, is when you have ischemia, the brain brings in hypertension as a compensatory mechanism to increase, basically to increase mean arterial pressure so that it maintains some level of critical perfusion. So I will look at hypertension in a patient with a head injury as a compensatory measure to actually have some substress being delivered. So I don't know if Dr. Cornelius, anyone can add on to that, but that's a pathophysiological mechanism that I'm aware of.
Yes, thank you very much, Dr. Isaiah, and thank you for Stella for that very good question. So it is almost always a compensatory mechanism because, like we said, like Dr. Isaiah said, cerebral perfusion pressure is equal to the mean arterial pressure minus the intracranial pressure. So once the intracranial pressure goes up, it means the cerebral perfusion pressure is going to go down. The brain has the capacity to actually raise the mean arterial pressure through systemic vasoconstriction. And so what you're going to see in this case is going to be a hypertension. Please do not treat that hypertension. The brain is trying to maintain the cerebral blood flow through increasing the mean arterial pressure. So do not treat the hypertension, rather treat the raise in intracranial pressure. So let's go to the next presentation for the interest of time. Let's have Dr. Joel Etum share his screen, and the rest of the questions that are coming in, we are going to deal with them as we go through this discussion that is going to go on up to the point of management of ICP. So Dr. Joel Etum is a second-year anesthesia resident who is going to give a case presentation on a patient with severe traumatic brain injury. And I think he's currently with Dr. Isaiah Chikwabanga, so he should be able to share his screen and be able to share what he has. The next poll questions will come probably after Joel Etum's presentation. So let's hold on and wait for him to share. Isaiah, please get Joel to share his slides as soon as possible.
Good evening, everyone. I hope I'm audible, Dr. Cornelia.
We can hear you. Proceed.
Okay, thank you. So I'm Dr. Joel Etum, second-year resident anesthesia. I'm going to be discussing briefly about traumatic brain injury, which most of us, I'm sure, have been faced with in critical care settings or even in the emergency department. Sorry, just trying to move this. So I'll briefly talk about the definition, the epidemiology. I'll have a brief case presentation, and we'll talk about the classification and initial management of TBI patients. So by definition, a traumatic brain injury is an insult to the brain, which is not of degenerative or congenital nature, that is caused by external force that may produce a diminished or altered state of consciousness and usually results in impaired cognition or physical functioning of a patient. Eventually, it can lead to a disturbance in behavior and emotional functioning. Another definition I came across from up to date is any alteration in brain function or other evidence of brain pathology in patients with a background of an external force. And generally, any patient that presents to the emergency department with any unaltered level of consciousness should be considered a traumatic brain injury until proven otherwise, especially in the setting of trauma. In the mechanism of injury, in most of our patients, as we know, they're usually involved in road traffic accidents or crashes. And it's been found that 50% of these patients are usually involved in motor vehicle accidents. And important to note also that even without a direct external impact, the simple acceleration, deceleration injuries of the brain can result in a traumatic brain injury in our patients. Then falls from heights also account for 20-30% of patients with TBIs. Firearms, such as in gunshot wounds, any foreign bodies penetrating the brain in the setting of trauma. Then work-related TBIs, for example, in the military with blast injuries or exposure to explosive injuries. The clinical presentation of these patients depends on the severity of the traumatic brain injury. And patients may present with headache, amnesia, impaired level of consciousness, vomiting, blurry vision, seizures, and with worsening ICP, the patients may have abducent nerve pulses, papilloedema, spontaneous periorbital bruising, and then the Cushing's triad, as Dr. Isaiah already discussed. In the epidemiology, globally, it has been found that TBIs account for 27 million cases with an age standardized rate of 369 per 100,000 of the population and a prevalence rate of 55 million, standardized to 759 per 100,000 persons, with an estimated rate of 8.1 million years of people living with disability as per 2016. Risk factors for traumatic brain injury, as you see most of our patients in the ICU are in the range of 20 to 30 years, so youthful ages, patients with low income status, unmarried individuals, members of ethnic minority groups, city dwellers, and more frequently we see males being involved in traumatic brain injuries than females. Then patients with history of substance abuse or intoxication commonly also present with traumatic brain injuries. And also it has been found that patients with previous traumatic brain injuries usually are at risk of a subsequent traumatic brain injury, possibly due to exposure to the same things that led to the initial brain injury. So the case presentation, I'm going to present a case of an 8-year-old male that we received in ICU recently. However, had been managed previously on the neuro HDO ward for about 12 days. So he was an 8-year-old male that was involved in a road traffic accident, knocked by a speeding motorcycle with subsequent loss of consciousness. There was no history of convulsion, ENT bleeding or CSF rhinorrhea or torrhea. Assessment at the emergency department by the admitting doctor found in his airway he had salivary secretions, and the intervention there was to suction and place an oropharyngeal airway to maintain patency. In the breathing, he had a respiratory rate of 25 breaths per minute. He was saturating at 94% on 5 liters of oxygen via nasal prongs, and chest exam revealed a symmetrical chest with equal air entry with transmitted sounds bilaterally. Circulation, he had warm extremities. Capillary refill time was 2 seconds. His pulse rate was 130 beats per minute. Blood pressure was 118/88. That MAP was 94. Heart sounds 1 and 2 were normal, and peripheral line was placed at 20 gauge, and blood samples were taken for the initial lab tests, including blood grouping, serum electrolytes, and chemistries. In the disability, his GCS on admission was 9/15 with a motor score of 5, eye opening of 2, and best verbal score of 2. And he had features of left hemiparesis, and they didn't have an RBS at casualty then. Exposure, the patient was a febrile, and patient was taken for EFAST, and it turned out to be negative. There are no features of any intra-abdominal bleeds or fluid accumulations. Sample history, he didn't have any known allergies, he was not on any medications, and he didn't have any significant past medical history. In the events around the injuries, he was first managed at Hoima Regional Referral Hospital, where he received an initial dose of mannitol, phenytoin. He was given ceftriaxone and metronidazole, given paracetamol, dextrose D10, and unspecified IV fluid, and this was all prior to referral to Mulago. And also a skull X-ray was done, which showed the left mandibular fracture. Secondary survey only revealed left-sided facial swelling, abrasions over left mandible and left and anterior chest wall on the left side, with no other injuries detected. So at that point, a diagnosis of moderate traumatic brain injury was made with the mandibular fracture, and the plan was to do a brain CT scan urgently, chest X-ray and the pelvic X-ray. He was instituted on, the plan was to maintain the IV ceftriaxone, paracetamol, IV phenytoin, and the maintenance fluids were normal saline in dextrose, 10%. And an NG tube was passed and urethral catheter, and later to have a OMF review for the mandibular fracture. So brain CT scan that was done, sorry, I didn't have a good image I could put here, but it revealed a contusion, a hemorrhagic contusion in the thalamus with no features of any raised intracranial pressure. Pelvic X-ray revealed a fracture in the right neck of femur. CBC showed a hemoglobin count of 9.3, white cell count of 8.61, neutrophils of 63, and platelet count was 260. This presentation was initially on his laptop, so I transferred another one on Isaiah's laptop. So the plan at that point was to transfuse 2 units of packed red blood cells, and upon your review, the patient was to transfer to the neuro HDU for further neuro monitoring. And then syrup epilim was also added onto his treatment regimen. Orthopedic review for the right neck of femur fracture, their plan was to do skin traction and splint the right lower limb, and OMF review was pending. So we shall come back to this case later on how we ended up in our ICU. Moving on to the classification of traumatic brain injury. Traditionally, we use the GCS because it's been known for long and it's reproducible and easy to perform. And generally, we use a GCS score of 13 to 15 for mild brain injuries, 9 to 12 for moderate traumatic brain injuries, and 8 or less for severe traumatic brain injuries. However, the alternative scoring systems, such as the full outline of unresponsiveness score, which is the first score, which was also designed to classify traumatic brain injuries, but I have a slide on it coming up shortly. And it was mainly made due to confounders associated with the GCS, such as in patients with sedation, ETT in situ, and that's why the first score came up. So this is basically showing the rating according to GCS, whereby mild injuries, usually there is a history of altered consciousness for less than 24 hours. In moderate and severe injuries, they usually have altered consciousness for longer, with also post-traumatic amnesia for less than 24 hours in mild brain injuries. Then for moderate, 24 to 7 days, and more than 7 days in severe. That's an outline of the first score, which is based on your eye response, motor response, brainstem reflexes, and respiration. But we do not commonly use this, but probably later people can go through this. And then the other ways of scoring are based on the neuroimaging scales, whereby we have, based on the injuries identified from your brain imaging, which could range from skull fractures, brain bleeds like epidurals or subdural hematomas, subarachnoid hemorrhage, cerebral contusions, and then features of intraventricular hemorrhage as well. So these are CT scan-based scales, such as the Marshall scale and the Rotterdam scale, which are used to predict risk of raised ICP in these patients. However, they are not commonly used in Uganda, but in neurotrauma centers abroad, they're commonly used. Maybe members can go through this later on, but they're based on the degree of pathology and midline shifts seen on the brain images. So, in the interest of time, going on to the pathophysiology. So primary brain injuries usually occur at the time of injury or impact, and they are as a result of the direct trauma or injury to the brain. And what is sustained usually, you can't do much about that because the injury has already occurred. And what happens is you have an impaired cerebral blood flow and metabolism with subsequent anaerobic metabolism and lactate production. Eventually, this leads to depletion of the ATP stores and pump failures with subsequent increased membrane permeability, including the blood-brain barrier. In the primary injury, as I've just mentioned, you could have a skull fracture, parenchymal lesions or vascular lesions. And this graphic basically shows your risk of raised ICP with each of these injuries, where you see that the risk is higher in patients that sustain contusions or subdural hematomas. And then the risk of mortality increases with those very injuries due to mainly increased cerebral parenchymal pressures and injuries. Whereas your risk is lowest with patients that sustain petechio-vascular injuries or epidural hematomas. So these images basically show you what the images would look like if you carried out a brain CT scan, where the first one shows evidence of brain edema with diffuse swelling of the brain, obliterating the ventricles. Then the next image shows a patient with diffuse axonal injury, where usually these patients have brain CT scans not in keeping with your clinical picture, based on an MRI. Then you could also have brain contusions, these hyperdense lesions you can see on the right frontal areas and also a bit on the left. Then subdural hematomas, where you have this concave shaped lesion with marked brain midline shift, and also an epidural hematoma. Then for secondary brain injury, basically what happens with secondary injury, it is as a result of the primary injuries. It can occur within hours or days following the initial trauma. And what happens is you have an accumulation of excitotoxic mediators such as glutamine and glutamate with release of free radicals, which continue to affect transport mechanisms within the brain with accumulation of cytoplasmic calcium. I have a graphic to show this. I think it will be easier to explain from here. So initially, so that you'll have the onset of an inflammatory cascade with loss of blood-brain barrier, increased blood-brain barrier permeability. So with macrophage infiltration, leukocyte infiltration, you have release of inflammatory cytokines. I don't know if that graphic is clear, which cause release of glutamate from the astrocytes. And this glutamate acts via NMDA receptors to cause intracellular calcium accumulation within the cytoplasm, and eventually have mitochondrial toxicity with release of reactive oxygen species and free radicals, which lead to neuronal death. And eventually you have also death of the axonal filaments with loss of neurotransmission and neuronal death eventually. So these are factors that exacerbate the secondary brain injury or can lead to worsening of the secondary brain injury. So principally, we know hypotension and hypoxia can result in worsening of your secondary brain injury. However, intracranial hypertension, because we have already discussed with Isaiah about cerebral perfusion pressure, so which can be compromised once you have increasing intracranial hypertension and pressures. And then anemia, hypoglycemia extremes, hypothermia, hypercapnia, seizures, and infection. So this is a graphic basically showing what I've been discussing. I'll move on in the interest of time. And basically talk about the approach to a patient that presents with a traumatic brain injury. Last week, we talked about a general approach to these patients. Of course, you have to have an early activation of the team on ground and organize and prepare for this patient if you had proper communication beforehand, or in most of our cases, we don't really get a communication. So we have to handle the cases as they come. So in these patients, you handle them like normal trauma patients. So basically in ABC, after assembling your team, be mindful of the C-spine as you handle the airway. So in case you have to intubate, because in patients with a GCS of less than 8, you have to intubate with manual inline stabilization to avoid worsening of the C-spine injuries and secure the airway. And then also you have to handle the breathing to maintain the oxygen saturation and do anti-dose carbon dioxide monitoring to maintain normocapnia. Circulation, insert large bore cannulas, 2 of them, and run your fluids of choice, which is normal saline in this case, as we're going to see ahead, and then take off your bloods for the initial labs. Disability, you have to assess, of course, the level of consciousness, check the pupils, and check your baseline sugar levels. Exposure, you have to fully expose the patient and ensure the patient is normothermic, and your adjuncts to the primary survey, if a scan to rule out other injuries, x-rays, and also your 12-lead EKG. Take a sample history and not forgetting to know the mechanism of injury, injuries found or suspected, vitals if you're receiving this handover from a medic, and then the treatments given initially before you receive this patient, and the other sample history. A secondary survey, and then a definitive treatment. I won't talk much about this because we really exhaustively covered this last week. I'll move on to the specific treatments. Talked about intubation for patients with GCS of 8 or below, or patients who have saturations of below 90 despite supplemental oxygen. And then also patients who may have signs of cerebral herniation may also benefit from intubation. Then monitor vital signs, assess other systemic trauma features as per ATLS algorithm and neurological exam. Then management of the ICP, DO labs, and then also administration of antifibrinolytics like tranexamic acid. So according to the CRASH trial, patients that received tranexamic acid for moderate to severe brain injuries, moderate to severe injuries showed benefit. If they receive tranexamic acid within 3 hours. And then of course, it should be a CT scan as soon as possible to detect any features of the skull fracture, intracranial hematomas, or cerebral edema. So for surgical management of these patients, usually it's for patients that have epidural hematomas, which are more than 30 mils, regardless of the GCS, or patients with GCS less than 8 with the anisocoria. For subdural hematomas, usually surgery is advised if it is greater than 10 millimeters in thickness, or you have a midline shift greater than 5 millimeters, or if you have a GCS less than 8. Or if you're monitoring, if it has decreased by greater than or equal to 2 points. Then for intracerebral hemorrhage, usually surgery is indicated if it's in the posterior fossa, with marked mass effects from brainstem compression, or if you have obliteration of the fourth ventricles, or features of obstructive hydrocephalus. For intracerebral hemorrhages in the hemispheres, it was not clear where the line is drawn for surgical intervention, but if we have any surgeons on call here, we can get their input. And also patients with penetrating injuries also are indications for surgical intervention for dural closure and prevent CSF leak. Then for depressed skull fractures, if you have fractures that are depressed greater than the thickness of the cranium, or if you have an epidural penetration or frontosinus involvement. For refractory hypertension intracranially, usually we do decompressive craniotomies to save. For intensive care management, basically the focus is to limit secondary brain injuries. And the general goals are to manage the ICP and keep it below 22 millimeters of mercury and maintain the cerebral perfusion pressures between 60 to 70 millimeters of mercury. I think the subsequent speakers are going to talk about intracranial hypertension management in detail, and then optimizing the oxygenation and BP and managing temperature, glucose between 7 to 10, and anti-seizure medications for these patients. So for initial ICU intracranial pressure management, usually we do baseline treatment, elevating the head of bed to facilitate venous drainage in order to maintain cerebral perfusion. And also for patients that have intubated, definitely loosen the ties around the neck, which can sometimes impair cerebral venous drainage. Then for osmotic therapy, osmotherapy, usually we use mannitol or hypertonic saline. And lots of research has been carried out to determine the best choice between this, and it's still controversial. However, most centers prefer hypertonic saline, especially in hemodynamically unstable patients, because mannitol would exacerbate your osmotic diuresis. Yes, Dr. Cornelius.
I'm sorry, I may have to cut you short, since ICP management will be talked about later on. Was there anything extra in your slides that that we needed to cover regarding the case that you presented?
So regarding the case, basically, okay. Maybe just an update on the case that I had earlier presented.
Please.
Yes, that we can skip to. So basically, the child has been admitted to ICU. I don't have the slide here. And the reason for admission today is death in the ICU. So this child had a worsening GCS on the neuro HDU, and the patient was admitted due to status epilepticus, and his GCS score on admission was 6/15. And so currently the child is intubated on mechanical ventilation, and the seizures have been controlled. He's currently on Keppra and sodium valproate, and he's undergoing neurocritical care support, basically. So, okay. Yeah.
So did you have a repeat assessment of the brain image-wise, just so we can understand if there was anything extra upon their admission?
Yeah, so currently we have not yet been able to get a brain CT scan, though we had requested for it due to logistical issues from the parents. And we are still trying to get a waiver for it, but we're managing the child as a case of diffuse axonal injury. But yeah, we still need evidence for that.
were there any signs of raised intracranial pressure besides the fact that they were having status epilepticus at the time of admission? Were there any other signs that indicated that perhaps the child is having raised intracranial pressure?
On admission, we didn't have any features suggestive of raised intracranial pressure. He didn't have any anisocoria. His BPs were okay. We're not having features of the Cushing's triad.
Okay.
Then,
All right. So I want to thank you so much for that presentation. Audience, allow me to hand over the microphone to Dr. Erasmus Okello, who is now here with us fully to take over the session. Dr. Erasmus, please, I'm handing over to you and I'll go back to the Kamoli. Thank you.
Thank you, Dr. Cornelius, for the moderation so far. And I would actually urge you that you've done an amazing job and I really wanted to continue. Nonetheless, more importantly, thank you so much for leading the team so far. To the presenters to this point, thank you so much for the job well done. And to the participants as well, thank you so much for the, for your active participation, especially the questions. And more important, the discipline. We don't have a lot of interruption with the noise during the presentations. Specifically, Dr. Joe, thank you so much for your presentation. I would like to call on the audience to share the questions they have so that we can proceed with answering them. As you notice, Dr. Joel's talk consisted of two sections, one being the aspects of the pathophysiology and the background management and the like, the basics of neurocritical care for trauma patients. And the second part really, which I want us to focus on as well, just so to understand the local picture, is the case presentation. So kindly unmute yourself, kindly raise your hand and we shall select you to shoot your question, and then Dr. Joel will answer it, or the faculty will assist. In the chat, Doreen Katshabe asked if coagulation studies at baseline would help. Joel, do you have an answer to that? Joel, kindly unmute and respond.
Yes, Dr. Erasmus. So what I came across was at baseline, the use of coagulation studies was mainly for patients that had been on previous anticoagulants, if you come across that in history. However, the issue of coagulation defects was mainly coming in the case of patients who are very hemodynamically unstable and had received massive transfusion protocols instituted at the time of initial management. So that's where I found the issue of coagulopathies coming in more for patients that were on massive transfusion protocols.
All right, thank you very much. And I hope that addresses Doreen's concern. So yes, we almost never really need to do a lot of these coag studies in this. Besides in trauma, most of them don't really do very well. So you select on a case-by-case basis based on the likelihood the patient's having some ongoing coagulopathy, and especially in patients who are requiring increasing blood products, so they're bleeding quite a bit. Definitely, if a patient has got underlying risks, like there's a history of some underlying coagulopathy, maybe an inborn error, or they're using anticoagulants at baseline, e.g. patients who are on chronic anticoagulation, then sure, those guys might need you to study that a little bit more. And then again, which test do you choose? Again, depends on the underlying issue. So if you have someone who's on warfarin, sure, INRPT will do a good job. So if someone who's on low molecular weight heparin, maybe for a DVT or PE, then sure, maybe you might want to do a factor 10A level. If someone is bleeding quite a lot, maybe you want to do, you might need to do a thromboelastogram. Just see, so that it gives you a bit of a broader picture on which kind of, what's causing the bleeding. Definitely baseline CBC gives you an idea about the platelet counts. And if you know about the systemic function, through renal function or liver function, then you might know if the liver or renal dysfunction might be contributing. But overall, not very many tests to go by to specifically advise you on bleeding. Factor levels, especially things like fibrinogen for people who have suspicious ongoing bleeding, help, might also help. But overall, rarely do we need these things. So I guess the next question that we have on the chat is, I see Dr. Cornelius helping us to answer some of the questions. It's quite good. What is the dose of phenytoin? Okay, that has been answered. What's the dose of phenytoin for seizure prevention in patients with traumatic brain injury? So if it's prophylaxis, really, we mostly just going with the low dose, it depends again on the pattern of injury and the likelihood the patient might have a seizure. But frequently, you're just going with just a simple dose of maybe 200, 250 milligrams twice a day of phenytoin for these patients. But if someone has already had a seizure, or you suspect patients kind of injuries, high risk for seizures, then definitely start by loading them. Loading dose of phenytoin ranges from 15 to 20 milligrams per kg, and then you follow that with maintenance dosing. Again, if you remember that quite a big proportion of these patients will have seizures, as you'll learn later on. And usually those seizures are non-convulsive, so they are subclinical, you may not be able to see them. So they're looking for someone who's got fluctuating GCS and the like. I hope that the next presenters will expound on that. But overall, if a patient has not had a seizure, you're just going with the prophylactic doses, which are really lower. But if they have had a seizure, or you suspect having seizures because of fluctuating GCS, you look at the pupils and they're really dancing around, then you might want to give them a loading dose and then go to the maintenance as treatment for a seizure. Let's see. All right, Okurut is asking how best they can get this, presentation, this recording later on. We shall definitely see how to distribute this later on through your different networks. If you could just let us know which institution, you hail from, so that we might be able to send this recording to a specific representative who can distribute, as we might be able to share with everybody. What are the components of the NeuroCrusher bundle when managing these patients? So Emmanuel, we should be able to share with you that in the subsequent presentations. I don't want to steal somebody's thunder. Someone is going to be presenting that in a bit.
Hello. Yes, hello.
Yes, Dennis, please, the floor is yours. Can you ask your question?
Thank you, Doc, for the opportunity. Thank you for the presentation, the presenters. I would like to ask my question about osmotic therapy. I would like to ask for the duration for which you can give it, and then how does it affect for patients who are having intracranial hemorrhage? Does it sometimes adversely affect the spread of the hematoma, or it does not? Thank you.
Shiondo, thank you very much for that good question. Let us, if you don't mind, if you could just wait out a bit. One of the next talks actually directly answers your question, sir.
Thank you, Doc.
All right, thank you very, very much. In the chat room, you'll get additional responses to some of the questions we are asking as we proceed. My colleagues, Dr. Cornelius and Dr. Peter Gava, are providing some answers to some of the questions we may not be able to answer immediately. So let us proceed. First, before we go on, we would like to post I think we will be posting some poll questions as we proceed. But in the meantime, I would like to introduce the next speaker. Kindly welcome Dr. Deborah Babirie. Dr. Deborah Babirie will be taking us through radiological aspects of the subject matter today. Dr. Deborah is a third-year resident. She's a student of radiology in her final year, that's year 3, and she will be taking us through CT scanning, brain imaging in traumatic brain injury. So hopefully this will help answer some of the questions we're asking about indications for imaging, when to get them, and also kind of help us with the basic interpretation. Frequently, we are chasing down radiologists to answer all questions about the CT scans we've received, when to do them, among other things, and how to do them, first of all. Hopefully we'll have answers to this in a bit. So kindly welcome Dr. Deborah. Kindly share your slides, Dr. Deborah, and take on the podium. Thank you. Yes, we can hear you loud and clear, my dear. Thank you so much.
Yeah, thank you very much. I've already been introduced, but I want to acknowledge one of our senior lecturers in radiology, Dr. Rem Joffre, who helped me with the preparation. So I'll be taking you briefly through imaging of traumatic brain injury. What exactly do we do? Okay, so that's our outline. We just talk most of the things that have been presented. I will not repeat, but that's the outline. So the definition has already been said. And yes, the diagnosis also using the Glasgow Coma Scale. Yeah, so in the most recent research, mild head injury actually is now being taken to be 14 to 15, but we are still using the category of 13 to 15. So some of the indications, and when I was looking at the indication, I was looking at the clinicians who are maybe meeting these patients, what would cause them to bring these patients for us to imaging. And most of the request forms that we have got, of course, patients with traumatic brain injury, and maybe they have lost consciousness, or there's post-traumatic amnesia, or patients with altered mental status, focal neurological signs, and all these other things, evidence of clinical deterioration, have all been some of the indications that we have been receiving these patients. So now it comes to us. When you send us these patients, when do we image? When should we image? Because as you realize that we are, radiology or imaging is not so cheap, it's a bit costly, and there's so many other things that are involved. And especially also one of the imaging modality that we use, the initial one, which is the CT scan, the computed tomography scan, it uses radiation, ionizing radiation, which might be harmful to the patient. So when you send us these patients, we do not just image. Not all patients with traumatic brain injury will require neuroimaging. So as we work out this, we have to know what guides us. We don't just select and say this one will go, this one will not. So we have some guidance, and there are two basic things that guide us. Number one, the GCS, the Glasgow Coma Scale. And here we look at the classification that we already talked about, whereby all the patients with moderate and severe TBI, we image. Those ones, there's no, we always image them. But the ones that cause us some challenges are the ones with mild TBI. And in these instances, we go ahead to use some guidelines, clinical imaging guidelines or algorithms that help us to know which one will require or will benefit from the imaging, taking into account the financial costs, the radiation, and the benefit. So these algorithms are mainly used in mild traumatic brain injury, and we have a number of them that have been researched and validated, but these are the ones which are commonly used: the Canadian CT head rule, New Orleans criteria, there's the NICE criteria, but there's also the American College of Radiology appropriateness criteria. Particularly this fourth one, the American College, they base imaging according to the indication. So it's like a guide whereby if you send in a patient with a certain indication, they will give you what imaging you can do, which is the best, or the other alternatives. They give you what kind of disadvantages or radiation exposures that the patient might get, any kind of indication, not only in trauma. It can be patient presenting with headache, so they will tell you what is the first, and also they do it according to the age. So it's a very good tool for physicians or clinicians to have around. But in our imaging, so far, we use these algorithms, and the Canadian CT head rule and the New Orleans are the ones which have really been studied and extensively researched. So what is in the Canadian CT head rule? Basically, there are 7 parameters which are grouped into high risk and the medium risk. The high risk patient or high risk category, we have patients with mild head injury, because remember now, moderate and severe, definitely we image. Now the ones with mild, if the patient comes in with a GCS score of less than 15 at 2 hours after injury, there is an indication to image. Or if they have a suspected open or depressed skull, any signs of basal skull fractures, vomiting, more than 2 episodes, if they are more than 65 years of age, if they have amnesia before impact of more than 30 minutes or dangerous mechanism, for example, patient has a pedestrian who has been knocked down or occupant ejected. So if the patient comes to you, even if they have mild head injury, but they have any of these 7, any of them, even if it's in the medium risk, that's an indication to image. And the New Orleans also has its 7. So what is being researched on, at least in our department, is the Canadian CT head rule. So I request that you go back and read about the others, the New Orleans and the NICE criteria, to familiarize yourself with. But what I wanted also to let you know, this tool, the Canadian CT head rule, is also being tested to see whether it can be applicable in our setting of Uganda, of Mulago. So we shall share with you the results that we come up with. So we're still talking about to image or not to image. So we say that those who have the moderate and severe TBI, we are going to definitely image. So the ones with the mild, the ones where we use the algorithms that I've talked about, and the 2 main things that have been found to be correlated with positive CT findings, duration of the loss of consciousness, and then the post-traumatic amnesia. So the other thing, so now knowing that this patient is fit for imaging, imaging is going to provide benefit, so we know what tests to order. What are we going to order? So of note, I had someone talk about skull radiography, but I want to let you know that skull radiography is now obsolete if you're dealing with if you're dealing with traumatic brain injury. It's really like just exposing patients to radiation with not so much research benefit. So we have a number of tests that can be done: CT, MRI, CTA, which is a CT angiogram or MRI angiogram, CT venogram, PET and SPECT. So I've written down some few comments. Like you see, CT is the best initial test. And why? Because it's fast, easy to perform, can be done in emergency settings, and there are really no special patient preparation. Unlike for MRI, where you have to make sure that the patient does not have any paramagnetic components, though it has a high sensitivity, but you also know about the availability or accessibility of MRI. So the CTAs and MRAs, these are angiograms and the venograms. They are not routinely done, and these are only done when you really suspect damage to the vessel. And with PET, still, when we don't have a PET in Uganda yet, we have a SPECT which will be starting to work very soon. But it's just to establish prognosis, because PET and SPECT, they use the physiology, what is happening. So they establish prognosis and they guide long-term therapy. Okay. So the performance, just something briefly about how these things are performed. The CT, we prefer a multi-detector CT scanner. And here we mean that this CT scanner can take a number of images at once. So you find that the whole brain can be scanned in actually maybe less than a minute. So which is very good for us in the emergency settings, that you can easily get to know what's wrong with the patient very fast and act fast. So, and it has no special patient preparation. Basically, initially we do the non-contrasted in the acute setting, but there could be some indications for the contrasted CT scanning later. Yes, hello? Okay, there's someone talking. All right. So we do cross-sectional imaging, and we also do the multi-planar, whereby you can have axials, the coronals, and the sagittals, but also we take at least 2 series, the bone window and the soft tissue window. So, and all the rest, since the notes will be availed, you can go through later in the interest of time. So when you do your CT scan, how to interpret, we start with something that is called a SCOUT or a scanogram, and it's also very important because it will help you detect some few things and like alignment, and you can also pick some subtle things. Now, for example, in this image, the patient had a Hangman fracture, which is a fracture through the pars interarticularis of C2, and they were able to see it. Maybe of note, I also wanted to tell you that in TBI imaging, we always include the cervical spine. So the other thing we do after obtaining your images, and now you're trying to interpret them, we look for air in any abnormal places, and this air can indicate fracture because it means air is moving from somewhere into where it's not supposed to be. But a technique of using the lung window, there's what we call a lung window. We use it in the chest, but you can employ it here to look for any small pockets of air. Then also we look at the soft tissue window, and in the soft tissue window, we're looking at the scalp and also the hematomas, intra and extra. So in the bone window, we're going to study, I'll have some images that I'll show you. This is just telling you the protocol, what we follow when we are interpreting. So now we come to the bone window. In the initial images, where we said soft tissue window, I think you can see that you can't see the bone so well, the different parts, layers of the bone with a diploic in between. But when you come to the bone window, you're able to see the bone well, and you can pick the fractures and or any others, actually any like subtle fractures. But of note here, once you see fracture through the temporal bone, it's because the protocol we do for main brain imaging is not the perfect one for the temporal bone. Temporal bone has so many other smaller things. So when you suspect fracture there, you can order for a protocol for the temporal bone to rule out fractures to those the bones, the ossicles, and all those other things. So we also can use bone window to study the sinuses, And when we have sinuses opacifying, they're usually supposed to have air. So when you have them opacifying, it can be an indication, something that can show that maybe there's a fracture somewhere. So you'll be keen to look at that place. But there's something also very important, the blood window. Blood window, it's us who can do it, like when you have an app or on the machine, you just have high contrast in the brain and it helps you bring out the bleeds better than before. So importantly, we have to use different planes, the coronal and the sagittal plane, because some things can be better seen in one plane or the other. So when we start, that was performance, when we start to interpret some of the things that I've said, I will not repeat. So we are looking at the primary injuries. This can be coup or country coup. I think we know what those two terms mean. But coup, it's that injury which occurs at the area of impact. Then the country coup, it occurs at the opposite area because of transmitted forces. But we can also look at the fractures and the hematomas. So secondary injuries, which have been already mentioned in some previous presentations, but mainly usually due to edema or swelling or the increased ICP. And we see the herniation, sometimes ischemia and infarction. So we look at symmetry of the south side. Is there symmetry? Or if you find one area of the brain, there's effacement. Effacement means that you can't tell out the gyri and the south side. Then you know maybe there's a problem here. So look at the symmetry of the cisterns, the ventricles. These are very particular places that we look at. The suprasellar cistern looks like a star. So you should be able to see in your images, you should see a star and a smile. Those two things should be looked out for. So this is a smile, and if you see your star and a smile, that is good. If you don't see the star and the smile, you start to worry. It means that maybe the brain there's some increased pressure and it's pushing onto those cisterns. So we also look at the gray white matter. When you're looking at the CT, we can tell where the gray matter is and the white matter and then the gray matter. So when you see that you can't really tell out which part is which, then you'll be keen and look at that area, and also some signal attenuations. So in the fractures, there are a number of fractures. You can have just a linear, non-displaced, non-depressed, but they can also be a diastatic when it's going through the suture lines and it enlarges the sutures. There might not be a specific fracture sometimes, actually, and you just see diastasis, suture enlargement, but you can have the bad ones where you have depression or displacement. And so most times clinicians like seeing the 3D. Yes, it's good, it helps you, but for some fractures, especially at base of the skull, the 3D might not bring them out so well. So train yourselves to also love these 2D images. Most times you go for the 3Ds only, but it might not give you the clear picture of what's really inside. It only gives you like the surface. So you can also look out for the hematomas, and I'm sure we know what these hematomas are. They are not something to really worry about, especially, okay, you can worry about them, but if it's children, then they become a very, very big worry. But then also, like when you see them, they can be an indication of a fracture at that point. So you're keen and look for that, any pathology in that area. So the different types of hematomas we have, the epidural. So we have our brain here, and we have to know the different layers for the brain as you come through from the skull. Then you have okay, let me start from the brain. After the bone, you have the dura mater, and then you have the arachnoid and the pia mater, which outlines the brain. So when there's any injury to the vessels for the epidural, it's mainly arterial. That's why it's not a good hematoma, because it's arterial, and you know arterial, how they give out a lot of blood. So the what we shall see here, we have the hematoma collecting between the calvarium and then also the dura mater. So it usually looks like a biconvex shape. It gives you that biconvex shape, and that epidurals do not cross sutures. So wherever, because you have the periosteum really tethered at the suture area, so epidurals do not cross sutures. However, there can be exceptions, especially if you have the extradural, if you have venous extradural hematomas, if they are for venous, or if they are fractures which are crossing that suture line. But that's not so common. So for now, we take that they do not cross sutures when you're looking at your images. And then also, when you see an epidural, you have to make sure that you look out for most like a fracture. And something very important here is what we call the swirl sign. The swirl sign means you have a hypodense area within the hyperdense area. So, and it's an indication that there is some active bleeding taking place. So those are patients to really monitor. And so you can also see this on MRI, but then also we have the subdurals. So the subdurals, they are connecting below the dura mater and the arachnoid. So what we see in the subdurals, we see they are presenteric in shape and usually veins. And so risk factors can be, you have advanced age, and you can also have a swirl sign in the subdural. But also the subdural hematomas can have, we can have the ones which are through the interhemispheric, like the hemispheres. If you look at this image, the pictorial one, that you see that the subdural area can connect with the interhemispheric fissures here. So you can have the subdurals collecting there. When you have blood within the interhemispheric fissure, that's a subdural hematoma. So still on MRI, you can be able to identify the subdural hematomas, and especially if they are very small. For such, these ones, you might miss on a CT, but with MRI, you can easily pick them. So of note, we have that hematomas also going through different stages, acute, subacute, and chronic. So the acute ones can be seen a bit better because they are mainly hyperdense. But as you go through the how blood changes sequentially, they become a bit isodense, like they are equal to the brain. At times you might miss them, but it's important to look out for things that can indicate a problem there. Like I told you, look for your salsal spaces, look for any midline shift, look for the gray white matter. So as you can compare with this side, you can tell, even if you don't know what can be happening here, but you can tell that there's an abnormality on this side. But later when they become chronic, now you have the hypodense, at times even becoming a fluid collection there, the hygroma. So we can also have subarachnoid hemorrhages. These ones are within the subarachnoid space. And importantly here, these are the main cause of hydrocephalus, the complication of hydrocephalus, because they will clot in there and maybe clog the granulations where the CSF is supposed to be reabsorbed into the system. So they're easily complicated with the hydrocephalus. So we can also have the parenchymal contusions or intracellular bleeds. The contusions, they are not so much a worry, especially if they are small, and they usually occur at areas where there is stiffness, like maybe bone or at the pulse. So you look out for, they can be hemorrhagic or non-hemorrhagic. And so contusions can also be clearly seen on MRI. So in this case, there's this contusion, which is hyperintense and it's being surrounded by edema, and better seen with some sequencing in MRI, which is known as the GRE or the gradient echo, picks up blood very, very well. So we also have the diffuse axonal injury. This is something which is challenging when it comes to imaging in CT, and yet it can be an indicator. patients who are ill, indicator of like severe brain damage. So on CT, we might not see so much. Sometimes you just see some hypoechoic. If they are non-hemorrhagic lesions, you might see just hypoechoic areas, but MRI will pick those areas very well. It will pick them out very well. So in cases where you have patients that their clinical state is not correlating very well with their CT imaging, these are patients who you may need to do an MRI. Though in some studies, they say that even if you do the MRI, it might not change so much your management, since you're not going to do so much to it, maybe just to know what could be the problem with the patient. So there's that grading, which people will go back and review, grading the severity of the axonal injuries. And also when they're hemorrhagic, you can see just small foci of hyperdensities within the brain. And when you see these small foci in a patient who is very ill, then this is just a tip of the iceberg. This is a patient where if you did the MRI, you'll be very surprised at what you see in terms of the axonal injuries. So that's still all talking about axonal injuries. Now we can go to the secondary injuries where we have, secondary injuries, which have already been talked about. So some of the common ones are the brain herniations. These are like some things which are like emergencies that we have to look out for. We can have subfalcine herniations or transtentorial. So the falx, you know where the falx is. So when you have brain herniating down below the falx, that's subfalcine. And then we know where the tentorium is. When you have brain herniating through, it might be going down or up, that's transtentorial. And that can also be imaged radiographically, as we are going on CT, as we're going to see in these images. You can also have actually the tonsillar. This is a mistake. It's supposed to be tonsillar herniation in the second image of MRI. But here it's showing you a number of those herniations. You can see that this part of the brain tissue is going onto the other side, and there's also this part which is going below the tentorium. So you can have many herniations occurring at the same time, though you can also have one. And these are secondary injuries which are due to indicate that there's increased intracranial pressure or there is edema in the brain. So for the brain edema, we basically diagnose it using the Hounsfield units. Hounsfield units tell us about the density of the different tissues. So when you receive your hard copy film, you might not be able to diagnose the brain edema. And at this point, I want to encourage all the clinicians, if you can be able to get that app, which can help you read these radiological images, because it's free. You can just download the app, and when patients come in with their CDs, you're able to read, because at times the hard copies might not give you exactly what you need, seeing that it's most times the radiographers who go and whatever pathology they think is there, they pick. But when it's been interpreted by the radiologist reviews the images again and makes an appropriate report. So the other complication or secondary injury can lead to hydrocephalus. That's like what we said. Hydrocephalus just simply means when you have your ventricles enlarged. So I just wanted to briefly talk about CT angiography. Lastly, it's not something that is routinely done. That's why I'm bringing it out the last slide, but it can really be of help. It's used to assess for injury to blood vessels, which can lead to complications like vessel dissection, aneurysms, or formation of fistulas. So it's performed when you suspect damage to a vessel. And when will you suspect damage to a vessel? When you have like a large intracerebral bleed, that's something that should not be taken just slightly for trauma. You have to suspect an extra damage maybe to a big vessel, and that's where an indication of CTA comes in ideal. And what the other thing, it helps you, okay, after we've known that it's vessel damage, it can help you form decision on how you're going to manage location and the approach and all that. So these are just images which were done, CTA. The angiogram means you give contrast and you study the vessel. So when you compare this vessel on the right, the carotid, and the one on the left, you can see that the left one is really small and there's some surrounding hypodensity, but which is not very clear. And when they reconstructed the image, you can see that the carotid vessel is narrowed, which was an indication of the damage to the carotid. But the other indication, other problem we talked about is the fistulae. You can form those cavernous fistulae, carotid cavernous fistulae, and patients will come in with all those symptoms of in the eye. Yes, or all the vessels, when you scan the superior ophthalmic vein, will be really distended and prominent. So this is the last slide, and I picked it in some article, like some schema for post-trauma imaging, when to do it and what exactly to do. So initially, you do the initial CT scan whenever you're possible or whenever, and what they recommend is a non-contrasted. The plain means non-contrasted, but then you can do it's not done routinely, but you can do a second one maybe 24 hours after surgery or post-trauma if you think the patient is not improving. But other studies can be done when you try to follow up the patient. But what I want to tell you that when you're ordering for these CT scans, please put into account two main things: the cost, but then also the radiation that you may be exposing to these patients. So once you're ordering them, it should be justified, and we have to optimize this imaging. MRI, we can't talk much about it, but like we know that it's very sensitive in imaging, but also CT has been studied and shown that whatever MRI maybe can provide in the acute setting, CT can equally do it, and without being missed. But in cases where you have clinical symptoms not correlating very well with your CT findings, then you send for the MRI. So thank you very much. I think that brings me to the end of my presentation. I hope it's been a bit clear.
Thank you so much, Dr. Deborah. That was quite rich and well delivered. Again, over to the audience in a bit for questions. Just so we know, just so that everybody is aware, these critical care rounds will be running weekly, every Friday, and we are adopting a multidisciplinary approach to them, because we know in anesthetics and critical care, we collaborate with different specialties. In this particular case, radiology is quite at the center of what we do in neurocritical care. And we managed to get the participation of the radiology department. So Dr. Deborah, Dr. Godfrey Erem, the representatives of that team, and I hope there are other members of the department in the audience. Thank you so much for this presentation, Doctor. So over to the audience. Do we have any questions? Kindly raise your hand and ask. Or post your question in the chat room so that we can proceed from there. Dr. Deborah or Dr. Erem, quick first question from me is what radiological features should we look out for suggestion of cerebral venous sinus thrombosis in trauma patients, or cerebral venous sinus bleeds in this patient, apart from the sign that you showed where the bleed can cross the midline? Is there anything else that we need to look out for? Because my understanding is that for you to diagnose these, you really need to suspect them, and as such, when you go reading a CT scan, you'd be looking out for them. That's the only way you might be able to catch them, as they might mimic a lot. So what radiological signs you'll be looking out for? That's the first question. The second question is, what radiological or what imaging tests or signs would you consider prognostic for patients with a traumatic brain injury? Thank you.
Yes, thank you, Dr. Erasmus, for those questions. I think Dr. Rem is still on. He will help me in answering, trying to answer these questions. But in cerebral venous thrombosis, when we have thrombosis, maybe in the vein, in those venous sinuses, at times you can end up with areas of ischemia and then also infarction. So when you have that high suspicion, like I said, that this angiogram or the venogram will come in when you have the high suspicion. But before you do the contrasted, because initially when patients come in, we do the non-contrasted. So when you see there's something that we call a hyperdense vein at time, or the empty delta sign, I don't know if I have an image for where the sinuses are being, I think I didn't include it, but that's like at the area where the venous sinuses, maybe the sagittal, the superior sagittal sinuses, at the area where they converge. At times you will see something like hyperdense. Since it's non-contrasted, once you start seeing the hyperdensities, then they might mean there's some clot within that vessel. And of course, there will be those other associated features like infarction or ischemia. Yes, maybe Dr. Rem can throw more light on that as we answer the one for prognostic signs for TBI.
Okay, thank you, Babiri, for answering that question. You've actually mentioned the issues. Usually, when we have a patient in the setting of RTA, we are commonly usually looking for blood. Okay, so we'll find either blood either in its acute form or subacute form, or if it's a non-hemorrhagic contusion. Those are the first things we want to pick, and the other associated complications basically of intracranial bleed, knowing that the brain is the rigid compartment and the introduction of fluid there is going to disrupt the anatomy and physiology of the brain. Yeah, so in other instances that there are uncommon findings of, for example, sinus disease or sinus injury or sinus bleeding. Yeah, so of course, if there's going to be a bleeding there, since it is a regional and geographical area where we are going to find affectation in the distribution, and of course the two most common accessible veins that we're going to have is the superior and then the inferior sagittals. Yeah, the superior in particular, there is falx cerebri there, and any trauma in the midline area can be associated with injuries to those blood vessels and bleeding per se. Yeah, but of course it is usually a difficult injury to pick, and most times I will either have to have a secondary look or a secondary imaging to pick things like that. The easier sinus problems to pick are usually the ones giving us ischemia. Yeah, the ischemia is going to be cortical, is still going to be geographical, but not in the anterior section. Yeah. So yeah, I think that's what I can say with regard to that. Babiri, over to you for the prognostic features.
Yes, thank you very much, Dr. Rem. I hope that is clear. So for the prognostic features that we can see on imaging in TBI, basically those features that we see, the secondary features that we see due to TBI, the things that we talked about that indicate maybe there's brain swelling, like edema, or there's infarction. So once we start seeing the herniations, then you know that this is poor prognosis for this patient. But also, okay, like, yeah, the herniations, or maybe if you suspect edema or the hydrocephalus. So those things can help us know the prognosis of the patient. But like I also noted about PET scan, the PET scan studies the physiology. So when we start using those PET CT or the SPECT CT, then we shall be able to more easily know how the prognosis of these patients with TBI, because we'll be studying the physiology of what is happening at the chemical level, let me say. The damage, how much has been damaged, because for the imaging we usually see like the gross picture, but with the PET, which studies physiology, you can see at that chemical level. Yes, thank you.
Thank you so much, Dr. Babiri and Dr. Erem, for that. So we're running out of time, and but we still need you. So a number of questions will be coming onto the chat. Kindly look into the chat and provide a written response, and I'll encourage participants to look that side. In the meantime, I'm going to proceed to the next talk. So we're going to switch it up. So far, we've done clinical, stuff. Now we are going to proceed to research-related stuff. So there have been a number of studies in the area of traumatic brain injury, and we're trying to paint a picture on what is best to do in TBI. So we're going to welcome Dr. Preech Kabata. Dr. Preech Kabata is an internal medicine specialist and critical care fellow with our SCALE program. He has got deep interest in critical care as well as immunology, and currently runs the ICU at Chirudu Hospital. He is going to take us through 2 landmark trials that have been conducted in the area of neurocritical care. Dr. Kabata, please take over. Thank you.
Good evening. Thank you very much, Dr. Erasmus, for the introduction. So today we shall be looking through the DECRA and the RESCUE ICP trials, and we shall try to critique them. In the interest of time, I'll summarize the trials, then we shall critique them through the strengths and weaknesses of the different studies. I'll start with the DECRA study because it was published first, then followed by the RESCUE ICP. So the first trial, the full name is decompressive craniotomy in diffuse traumatic brain injury, and it was published in April 2011 in the New England Journal of Medicine. And the main research question was in patients admitted to the ICU with severe diffuse traumatic brain injury and refractory raised intracranial pressure, does early decompressive craniotomy improve functional outcomes when compared with continued medical management? And the brief summary was that traumatic brain injury is common and reason for ICU admission. with a raised intracranial pressure is an important cause of secondary brain injury, and many patients with TBI get refractory raised ICP, which does not respond to fast-tire medical interventions. I will define for you what fast-tire medical interventions are. Then decompressive craniotomy is used as treatment for refractory ICP in traumatic brain injury, with some retrospective trials suggesting a mortality benefit. To be specific, these trials were not controlled trials. However, no large randomized controlled trials had been previously conducted. So the design, the DECRA study was an international multi-center randomized controlled trial, and it randomized patients within 72 hours of injury. And the trigger for randomization was refractory raised intracranial hypertension pressure, defined as ICP of more than 20 millimeters of mercury for 15 minutes, either continuous or intermittent, within 1 hour, despite tier 1 interventions. And then they were stratified according to center and the ICP monitoring technique. And they were randomized in blocks of 2 or 4 patients. Treating teams were non-blinded to allocation. However, outcomes were evaluated by 3 blinded assessors. A structured telephone assessment was used. And because of the nature of the topic they were trying to investigate, an intention to treat analysis was used. Then written informed consent was sought from the next of kin. So in the setting, these were 15 ICUs in Australia, New Zealand, and Saudi Arabia, all with advanced neurosurgical management capabilities. And the enrollment was between 2002 to 2010. The inclusion criteria, we had severe non-penetrating traumatic brain injury, which was defined as either a GCS between 3 to 8, post-resuscitation or pre-intubation, or a Marshall class 3 injury on CT imaging. And they needed to be less than 72 hours from injury. Exclusion, we had not deemed suitable for full active treatment, dilated and reactive pupils, mass lesions, unless too small to require surgery, spinal cord injury, arrest at home, and ICP intracranial pressure that is controlled. So the intervention that they did a decompressive craniotomy, that plus standard care. Now, this standardized surgical approach was large bifrontotemporal craniectomy with bilateral dural opening. The sagittal sinus and falx cerebri were not divided. And I put this image here. So they opened like the full front of the head, bifrontotemporal parietal craniectomy. Now, the control received standard care based on BTF guidelines. Protocol allowed life-saving decompressive craniotomy after 72 hours from admission. And that is why they went back to an inpatient analysis. Now, management that was common in both groups. So patients had ICP monitored, either extradural or parenchymal catheter. Then treatment whenever ICP was more than 20. And first-time interventions, as I had mentioned to you, these included sedation, optimization, partial pressure of carbon dioxide normalization, mannitol, hypertonic saline, neuromuscular blockade, and external ventricular drainage. Now, second-tier interventions for refractory raised ICP included mild hypothermia. It is important to note both trials were before the Eurotherm that removed hypothermia. So the secondary tier included mild hypothermia and barbiturates. Now, second-tier interventions could be used following randomization in the surgical group. Now, the outcome from this DECRA study, the primary outcome was median extended Glasgow outcome scale at 6 months. And in the craniectomy group, they scored 3. In the standard care, they scored 4 with an odds ratio of 1.8. Just to put it in context, this is the extended Glasgow outcome. So you can find that people who had undergone craniectomy scored 3. That is lower severe disability. Description, they're dependent on others for care. and people undergoing medical care scored 4, meaning upper severe disability, independent at home. From here, you can see that the people who had undergone craniectomy had a poorer outcome than people undergoing standard of care. Now, the secondary outcomes are the proportion of unfavorable outcomes at 6 months. 70% of patients with craniectomy had unfavorable outcomes compared to 51% of standard care, with a significant p-value and also odds ratio, which was significant confidence intervals. Now, the mortality was literally similar between the two groups, 19% versus 18%. However, in the intracranial pressure, the mean ICP after randomization was 14.4 in the group that underwent craniectomy versus 19.1 in the group that underwent just had medical management, meaning it was significantly dropped in the craniectomy group, and this was statistically significant. Now, ours with the ICP more than 20, you can see here it was 9.2 in the people undergoing craniectomy and 30 for the people who had medical treatment, again, significant. Now, as a result, the surgical group required significantly less first and second tier medication interventions post-randomization. Now, they analyzed further duration of hospital intervention, days on mechanical ventilation. Again, people who underwent craniectomy had fewer days of mechanical ventilation. It was statistically significant. They also had fewer days in ICU, and they had, and the days in hospital, they were similar. It was not statistically significant, but there were fewer in the team that underwent craniectomy. Now, the author's conclusion: in adults with severe diffuse traumatic brain injury and refractory intracranial hypertension, early bifrontotemporal parietal decompressive craniectomy decreased intracranial pressure and the length of stay in the ICU, but was associated with more unfavorable outcomes at 6 months. And now that is very important for us to understand. Now, one of the reasons they gave was that probably after you do the decompressive craniectomy, rightly so, you expect the injured brain to swell and therefore accommodate extra space, but they were suspecting that the increased swelling of the brain ends up stretching axons, and there's documented evidence that this stretching of axons, even after decompressive craniectomy, actually leads to a poorer outcome. So therefore, that was the thing. So the strength of the study, it was a large randomized controlled trial across 15 ICUs in 3 countries. No patients were lost to follow-up or withdrew consent, and 96% of the patients received assigned treatment following randomization. 3 patients of intervention group did not receive craniectomy, and 2 patients due to stabilizing of the ICP, and 1 due to incorrect randomization. Standardized protocol for medical management, which was consistent across the sites, was based on Brain Trauma Foundation guidelines, and the Glasgow outcome score, the extended one, is well validated too for assessing brain function. So those are the strengths of that study. However, this study was plagued with very many weaknesses. The first one is that treatment teams are unable to be blinded to group assignment due to nature of neurosurgical procedure. And of course, this is expected from the beginning. You couldn't blind the teams because there was active surgery. Now, another one, over a third of the patients were recruited from one center, that's important, and 8% of patients were from Australia or New Zealand. Now, there was a long recruitment period over 8 years, and then some clinicians suggest a cutoff of ICP more than 20 for 15 minutes is too low or early to trigger surgical intervention. Hypothermia to 35, which is now thought to be potentially harmful, was able to be used as a second-tier intervention. However, it was not reported. Now, this is important to remember. The Eurotherm 3265 study said hypothermia actually is not good. I'll mention it at the end. Now, the primary outcome changed midway, and this is very important. Changing goalposts sometimes is not good. So the primary outcome changed midway through the trial. However, both outcomes were reported and both statistically significant at the end of the trial. Now, differences in people reactivity at baseline is a potential confounding factor, and adjusted outcomes are no longer statistically significant. So they had found that people who had craniectomy had more dilated pupils, but then they controlled for this and therefore they removed some significant outcomes. And there was crossover from the standardized group to the craniectomy group. Crossover was allowed after 72 hours, is still considered salvageable and had uncontrolled ICP despite their penton infusion. And nearly a quarter of the patients crossed over. Now, these ones are 5% of the control group received craniectomy prior to 72 hours, 18% of the standard group of care underwent decompressive craniectomy after 72 hours as a life-saving procedures. This may be why there was no mortality difference between the groups. Now, also importantly to note is that 56 out of 70 craniectomy patients underwent cranioplasty within 6 months, which may have additional complications contributing to 6 months functional outcome. That is very important. And overall complications between the two groups was similar. Importantly also, the trial specifically assessed bifrontotemporal parietal without division of the falx cerebri. Now, other surgical techniques may have favorable outcomes or less complications. Now, patients with mass lesions were excluded from the trial, and therefore the results cannot be generalized to this population. As you can see, there are very many weaknesses to this study. So the take-home message from this one, yes, decompressive craniectomy did not, it reduced hospital stay, it reduced ICU stay, but at 6 months, the patients had a poorer outcome compared to patients who responded only to medical treatment. And as I've explained, it is probably due to other mechanisms. There's something called syndrome of trephination. Probably it is one that affected the cranioplasty. Yeah. Now let's move to the next one. Now, the next one, probably they learned from their mistakes. And now another study was done and it was published in 2016, a trial of decompressive craniectomy for traumatic intracranial hypertension. Now, the clinical question here was in patients with traumatic brain injury and refractory intracranial hypertension, does decompressive craniectomy result in more favorable mortality and neurological outcomes at 6 months compared with barbiturate coma and continued medical management? The trial design. So this was an international multi-center randomized controlled trial, parallel group superiority, 1-to-1 randomization with the use of permutated blocks of random sizes with stratification according to trial sizes. They were modified, excluded patients lost to follow-up or withdrew consent, and a sample size of 400 was calculated to calculate a 15% difference with a power of 80. And yeah, so the primary outcome was, the primary outcome measure was analyzed with an ordinal analysis method based on proportional odds method. The setting, 52 centers in 20 countries, so it was a bigger trial. All trial sites were hospitals that provided acute neurosciences care for patients with severe traumatic brain injury and had access to 24-hour neurosurgical services. 71% of the patients were recruited in the UK, and it was between 2004 and 2014. The inclusion criteria was patients with a TBI with abnormal brain CT and raised intracranial pressure more than 25 for 1 to 12 hours, despite stage 1 and stage 2 measures. We shall see them. And they should be between age 2 to 65. The exclusion criteria were patients with bilateral fixed and dilated pupils, bleeding diastasis, or an injury that was considered to be unsurvivable. So you can see they had already learned from some things from the previous trial. So in the intervention, they did decompressive craniectomy, continued stage 1 and stage 2 treatment plus decompressive craniectomy. Now, very important in this, very important to note in this group is that they did either unilateral frontotemporal craniectomy, that is hemicraniectomy for patients with unilateral hemispheric swelling, or bifrontal craniectomy for patients with diffuse brain swelling. Remember, in the previous study, all of them, they did bifrontotemporal, but these ones, there was either or, depending on where the lesion was. Now, the control group received, the medical group continued receiving stage 1 and stage 2 treatments plus barbiturates. Now, this is what they all received. So stage management common to both groups, we had stage 1 and stage 2 treatment were provided prior to stage 3 therapy, which is the intervention or control group. Now, stage 3 therapy was commenced if the intracranial pressure exceeded 25 millimeters of mercury for 1 to 2 hours after initial stage 2. Now, stage 1 therapies, these were head elevation, ventilation, sedation, analgesia, paralysis, central venous pressure monitoring, arterial blood pressure, and intracranial pressure monitoring. Now, stage 2 components that were done included commenced if intracranial pressure remained above 25 after stage 1, and this included continuing stage 1 treatments and optional treatments. These included ventriculostomy, inotropes, mannitol, hypertonic saline, loop diuretics, hypothermia. Again, the Eurotherm results were not out. Barbiturates were not permitted. Now, in the primary outcome, the extended Glasgow Coma Scale at 6 months after randomization for craniectomy versus medical group, we can see death was 26% in the patients that underwent craniectomy compared to 48% in the patients that underwent medical management. Vegetative state was higher in the patients that underwent craniectomy compared to the patients that underwent medical treatment. Lower severe disability, again, it was higher in the patients that underwent craniectomy. Upper severe disability, again, was higher in the patients that underwent craniectomy. Lower moderate disability was almost equal. Upper moderate disability was higher, and lower or upper good recovery was higher in the patients who underwent medical treatment. Now, if the Glasgow outcome score, the extended one, is in group 3, is grouped into 3 categories: dead, this is severe disability and etc. Craniectomy group basically had lower values for the dead, but they had higher values for the disabilities. In the secondary outcome, again, they looked at this Glasgow outcome extended score at 12 months after randomization. Again, death, as expected, was lower in the craniectomy group. Vegetative state here, it was higher in the craniectomy group, again, almost expected. Severe lower disability was also almost similar. It was higher in the craniectomy group, and upper severe disability was also higher in the craniectomy group. Now, the difference here, you can see the lower moderate disability was higher in the craniectomy group after 12 months compared to the other team. Then the upper moderate disability was higher in the medical group, and upper and good recovery was higher in the craniectomy group. And the upper good recovery was higher in the medical group. And so craniectomy group, they had fewer dead, more vegetative state, and more in upper good recovery. Now, the author's conclusion is that at 6 months, a decompressive craniectomy in patients with TBI and refractory intracranial hypertension resulted in lower mortality and higher rates of vegetative state, lower severe disability, and upper severe disability than medical care. Now, the strength of this trial is that all trial sites were hospitals that had immediate access to 24-hour neurosurgical services. Exploratory analysis examining the effect of covariate adjustment, for example, age, Glasgow Coma Scale, motor score, pupillary reactivity, and muscle grade of the CT pre-randomization were pre-specified, and that was very good. Similar numbers of patients in 2 groups received stage 1 and stage 2 treatment. Timing for initiation of stage 3 was similar in both groups. Agreement for participation in the study was obtained from the next of kin preemptively on admission so that initiation of stage 3 therapy was not delayed. A randomization code was not released until the patient had reached stage 3 of the protocol, and extended Glasgow outcome scale is well validated global outcome measure to assess functional independence, work, social and leisure activities, and personal relationships. Now, explanation provided for the reason for the GOC results were reported descriptively at 6 months. The proportional odds assumption was rejected. Compared to the previous study, this one had fewer weaknesses. So there was slow recruitment over 10 years, with 50% of centers only recruiting 3 or fewer patients. Therapeutic hypothermia, which is optional in stage 2, may have a deleterious effect on neurological outcome after TBI based on Eurotherm 32-35. However, the study was commenced before Eurotherm was published, and while it is not a criticism to the study, this may have affected the overall outcome. Clinical teams cared for the patients who are aware of the trial group's assignments, again, because of the nature of the intervention. And a large proportion of patients in the medical group underwent decompressive craniectomy, that is 37%. Remember, it's an intention to treat analysis. This situation may have diluted the observed treatment effect. 10 patients were excluded from all analyses owing to withdrawal of consent or lack of valid consent, and 7 more patients in the medical group were lost to primary follow-up. Long-term outcomes of survivors with severe disability would be useful. This follow-up data may be planned for the future. So, take-home message. If someone has had severe traumatic brain injury and they need decompressive craniectomy, yes, they might survive, but their functional outcome at 6 months may be poor. In terms, they may either be vegetative or otherwise. And that's why they were saying that in such scenarios, it is important, although very difficult, it is important to have things such as advanced directives. Thank you very much.
Lovely, 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 Dr. Preach. Thank you so much for the quick run through some of these 2 groundbreaking trials. We are definitely short of time, and I would like to welcome questions quite quickly, guys, for Dr. Preach. But maybe first one from me. Regarding the poor outcome of people who actually had surgical interventions in the DECRA trial, do you think there may have been an element of people who actually were made to survive with the more severe disease, therefore turning up with bad outcomes later, and the guys on the medical side may probably have had less severe disease and hence the not so severe outcome later on? What do you think?
Thank you very much for that question. Now, if we are to go back to these studies, the intervention in the DECRA study was at the baseline of ICP of 20 millimeters and above. For the rescue, ICP was 25 millimeters and above. But as you have correctly said, if you have terrible injury, you will reach that intervention stage before the other group. So I think people who had undergone craniectomy were sicker, but because of this very invasive procedure, so it really tries to make you better, but the primary injury, I think it is so terrible that even if you have this very invasive procedure, your outcomes are still poor. And that's why, again, we reiterate that they reiterated in their summaries that advanced directives are very important. And having these discussions with families, it's very important, because decompressive craniectomy can just lead to a vegetative state, and probably a vegetative state is a worse state than death. Thank you.
I don't know if I would like to just edit the use of the language there. That does decompressive surgery lead to a bad state, or is that the bad state, the bad clinical picture that requires decompressive surgery is likelier to cause a bad outcome despite or in spite of the surgical intervention?
Yes, as you have said, it is the bad picture before the decompressive craniectomy that leads to a terrible state.
All right, thank you very, very much. We saw something similar to this with CPR in that trial that compared the adrenaline use in CPR to placebo, I think to saline placebo, and they found that adrenaline led to more people having ROSC but the neurological outcome was just so terrible. So which probably means that you'll have an intervention that can prolong life or even give it an opportunity, to live again technically, but the quality of life is now what we're really focusing on in all this critical care game that we are playing. So thank you, Dr. Preach. Let me see. If you have any questions, guys, kindly raise your hand. I'll have 2 minutes for those questions before we have Dr. Kalunji take over. Let me look at the questions in the chat. Oh yeah, so Dr. Ellen is commenting that it is striking in this study that 37% of the medical group eventually received a craniectomy, which probably suggests that it is not an either or. So in other words, surgical management versus medical management are not necessarily things you're going to compare as to compare. In others, the clinical picture of the patient is going to determine what you do, but maybe given the outcomes, maybe surgery, by the time a patient needs surgery, it just means that they have really suffered significant injury and the outcome may still end up being so poor. So I guess the discussion really needs to put into consideration all those facts before a knife is put on skin. All right, so 1 minute for any questions.
If I can comment on what the doctor has said, and that is why it is important to have an intention to treat analysis type of study. So the intention to treat, if you have one group supposed to go surgery, another group supposed to undergo medical treatment. If one group needs if one group in medical treatment needs surgical treatment, they will definitely be given, but the analysis will still keep your original randomization. Yeah, thank you.
All right, thank you very much, Dr. Preach. Dr. Preach, thank you. Would like to excuse you for now. Before we invite Dr. Joyce, Dr. Cornelius, could you run the next poll question? And then we proceed from there. Dr. Cornelius, over to you.
Yeah, the next poll question is here. So this is about radiology. Which of the following would call for an immediate emergency brain CT scan in TBI? So you can start responding. We shall probably have about a minute and then end the poll, and then probably do about 3 polls and then move to Joyce's presentation. Okay, the responses are coming in and we have about 10 seconds to close this poll. So in a few seconds, we'll see the results of the poll. Okay, I will close the poll now. About 35% of you have responded, and this is the results. Majority, 57%, post-traumatic seizure would call for an immediate emergency brain CT scan in TBI. Dr. Rasmus, any comments on that?
Yeah, I think the majority of the guys are thinking right. So in terms of prioritizing, you want to know whether you want to CT scan within 1 hour or in others immediately after diagnosis and stabilization of a patient who has got TBI versus waiting a little bit longer. All the options in the poll question require a CT scan to be done at some point. However, people who develop a post-traumatic seizure will require an immediate one because it probably highlights an ongoing deterioration that needs to be caught early enough. The rest might wait unless there's some other mitigating factor. That is, of course, in relation to the fact that you might be operating in a facility where the CT scan is not exactly readily available resource, or there are many patients in line, or the patient has got other pressing care needs. So you may delay for some patients without necessarily affecting the outcome. Thank you.
All right, and then the next poll is really about the study that Preacher has presented. So knowing what you know now, if you are a patient who needed decompressive craniectomy, would you wish to have it? So we shall take about, I think this one should be really easy to answer without thinking. So probably give it about 40 seconds, and I will close the poll. So the reason this was included is you probably are more informed than your patients about decompressive craniectomy and the potential outcomes. So you should be able to decide for yourself before, God forbid, you get TBI. Okay, so the 40 seconds are up, and I will close the poll. We had a 50%, more than 50% response. Over 65% of you would wish to still have the craniectomy. Dr. Erasmus, would you wish to have a craniectomy yourself?
That is blackmail. The reality is that I do believe in personalized medicine a lot, and especially in the area of neurocritical care, there are probably, as we shall learn in a bit, newer assessment tools for brain function and brain function monitoring that could inform a lot more on whether I am safe or not. And at an individualized level, I could choose to proceed or otherwise. But given the setting we are in, the difficulties with the pre-hospital care, retrieval, optimization, transport, and then eventually the ED management, and then finally ICU management, plus or minus surgical management, I really think that the outcome will be extremely poor for me or my patient in this setting. And I think probably we might be kinder to ourselves, our patients, as well as the nation, with deferring some of these procedures and just giving the family the guidance in conversations to potentially forego it. So personally, I think I would not elect to go for DCRA, the decompression craniotomy.
And then Preach, you're the one who presented this. Yes, no, from you.
I think I would just want to rest. So no, thank you.
Okay, final poll before we go into the talk. What is your choice of fluid therapy in severe TBI? We shall also take about a minute for this one. So just select what fluid you would select for severe TBI patients. This is largely for either you're resuscitating or you're providing maintenance, whichever. Okay, interestingly, without biasing the audience, Balance Solutions are highly competitive here with normal saline. I think let's keep going along those lines. I hope no one will select, it doesn't matter. So we have about 10 seconds to the end of the poll. So in a few seconds, I will end submissions. Okay, that's the end. So I will share the results. So from this, 59% selected normal saline and 41% selected Balance Solution. So Dr. Erasmus, I think let's go into the discussion, and then we shall come back to this poll after Joyce's discussion on tiered management. Thank you.
Absolutely. Thank you so much. Thank you for participating in the polls, everyone. So next and our final presentation for this evening. Again, apologies to everybody. We shall overshoot a little bit today because of how rich the conversation is today. So next presenter is Dr. Joyce Kalungi. Dr. Joyce is an anesthesiologist and critical care fellow under our scale program. She currently works at Kawempe Hospital, where she is part of the team keeping our women alive, but deeply interested in almost every kind of patient in her critical care practice as well as study. So she will be presenting neuromonitoring and tiered management of intracranial hypertension, which hopefully will shed more light to some of the poll questions I've asked, as well as some of the questions you were asking earlier on. So over to you, Joyce. Thank you. Joyce Kalunji, kindly take over.
Good afternoon, sorry, good evening, everyone. In my background, there's a bit of music, but.
Joyce, please, if you can find the...
Yes, in just a few minutes, we'll have passed. Thank you, Dr. Erasmus, for the introduction. I hope there isn't too much interaction. So yeah, that's the topic I'm going to talk about. Briefly, I hope everyone is not tired. So that's the outline. Yeah, so we are going to talk about neuromonitoring today. So the topic we are largely addressing is intracranial pressure. Although intracranial hypertension can be caused by various circumstances or disease conditions like we'll be talking about, basically TBI is the most studied. So most of the guidelines are directed towards that. Yeah, so as we all know, and this has been illustrated by the previous speakers, normal intracranial pressure basically in adults should be less than or equal than 15 millimeters of mercury. So we consider it to be pathological if it's above 20 millimeters of mercury, although the current guidelines say about 22. This is an arbitrary figure, of course. Yeah, but that's the consideration for which most interventions will be initiated. The causes include trauma, any form of space occupying lesion that may be a tumor, abscess, stroke, hydrocephalus. It could be infectious causes, metabolic encephalopathies, venous outflow obstructions, CSF disturbances in either CSF production or CSF absorption. So again, as earlier on illustrated by most of the presenters, when you get, so the examples I'll use will mainly be traumatic brain injury. So when you get a traumatic brain injury, the first injury we sort of cannot prevent, that is the primary injury. What we can prevent is the secondary brain injury. So management of ICP is the mainstay in treatment of secondary brain injury. So that means it requires prompt recognition, monitoring, and we need to direct our therapies and eventually evaluate our therapies while monitoring ICP. So with ICP, the causes of ICP, because ICP can be focal or global. So when there are pressure gradients within the brain, largely this leads to cerebral herniation. And although also global increases in ICP, that's largely throughout the brain, can reduce cerebral blood flow and essentially lead to ischemia. And that will largely be global ischemia. So this has been well illustrated by the speakers before. I will not repeat it. The brain having three components: brain parenchyma, blood flow, CSF. Of course, when someone gets ICP, the first compensatory mechanisms are usually to reduce cerebral blood flow or to reduce CSF drainage. So usually those are the first mechanism. The other thing to note is cerebral blood flow. Again, like we've talked about the various mechanisms that control it. Remember, in traumatic brain injury, there will be people who will have a dysregulated blood-brain barrier, and therefore they have a disturbed cerebral blood flow. So I think as we advance more, we'll move away from just ICP monitoring to even cerebral blood flow monitoring, because you can still have, if you have a dysregulated blood-brain barrier, it means even when your ICP may largely be within the normal range, with just mild increases in mean arterial pressures or other physiological changes, you may get drastic increases in cerebral blood flow. Yeah, so that is something that we also need to look out for. The thing that I'll also emphasize on is, remember, ICP is largely a component of, as illustrated in those images, of the volume of each component and the compliance, as the Kelly-Monroe doctrine illustrates. So past the compensatory mechanisms and cerebral compliance, past the compensatory mechanisms, it means that with just tiny changes in volume of any cerebral component, there will be drastic increases in ICP, and that is when patients largely decompensate. So, so for neuromonitoring, of course, neuromonitoring starts with clinical features, some of which have been illustrated before. But these clinical examinations are done on patient presentation, and when the patient comes to the ICU, they are repeated on a 1 hourly basis. So some of the clinical manifestations of increased ICP will be headache. That's from will be headache, vomiting, loss of consciousness. You'll have focal neurological deficits. I repeated that more than once. That can include nerve 6 cranial palsies or decelerate posturing, hemiplegias, pupillary dilatation that can be bilateral or unilateral. Yeah, and of course, there's the Cushing's triad that we all know. Of course, this is ICP in itself is an emergency, but this is an implication of herniation. And yes, the other things that can also illustrate ICP is radiological imaging, like our friends have illustrated on the brain CT scan or MRI, the various features of ICP that can be noted. So with ICP monitoring, so currently, according to the guidelines, empirical therapy for ICU, for presumed ICP monitoring is unsatisfactory. In other words, you examine the patient or you take a history, and then, which is what we mostly do in our setting, you can see that there are signs of ICP, so you presumably initiate empirical treatment for the ICP. And that it's largely unsatisfactory because, again, based off the formula of cerebral perfusion pressure, you know that that's equal to mean arterial pressure minus ICP. So you're going to presumably think maybe your ICP is about 20, okay, 20 and above. So you're going to target a mean arterial pressure of maybe, let's say, 80, or rather, okay, let's say 70 to 80, such that you have a cerebral perfusion pressure of largely 50 millimeters of mercury. So you're doing a lot of guesswork rather than having to measure it accurately and get a value. Secondly, we know that some of the interventions that we stage are temporary. They wear off after a certain period of time. So that means that the only way to evaluate your therapies is to continuously have a monitor in place. So the reason why we monitor ICP is to maintain an adequate cerebral perfusion pressure and essentially cerebral oxygenation. Those two may not be synonymous, but yes, they are presumed to be. So the ICP monitoring can be done invasively or non-invasively. We'll talk about the invasive monitors in detail because they are currently the gold standard. So, so the invasive monitors are usually inserted. There are different types. We're going to talk about them. And then usually you transduce the pressure, just like it's done for arterial blood pressure monitoring. So the type of ICP monitors that we have, invasive monitors that we have, they can be intraventricular, intraparenchymal, epidural, and subarachnoid. So the intraventricular, which is an EVD, is currently the gold standard. Some of its advantages is that it's largely easy to insert, except of course if there's a lot of ICP and there's compression of the ventricles. It's the most accurate measure we have for ICP. It also largely enables drainage of CSF. The disadvantages of having an EVD in situ is that it's associated with a higher risk of infection, hemorrhage, and then after insertion, of course, like we'll see, the position of the patient, the patient has to be fixed. So any changes in position of the bed or the head would change the value of the value that you're getting. So yes, also the other advantage is that it can be easily recalibrated, like we'll see. So this is an image showing you an EVD in situ. Of course, a tiny incision is made, and that EVD is directed into the third ventricle. This tubing is later on, it's connected with a three-way clock, and it's connected to a bag, a three-way clock that's connected to a pressure gauge, a pressure gauge with a transducer, a pressure gauge, a bag, and then also an arterial transducer. So ideally, especially in cases of high ICP, the CSF should continuously drain, and then the ICP should be monitored intermittently. So of course, the ICP monitor will give you a value, a definite value, but it will also give you a waveform analysis. So right here, we also see an intraparenchymal catheter that's mainly inserted in the frontal lobes. So if we were to talk about, so the intraparenchymal catheter largely has, it can be made of either laser or electronic with a probe that can measure pressures. Like I've said, it's largely inserted in the frontal lobes. The issues with it is you cannot drain CSF with it, and it also cannot be easily recalibrated. There's also what we call a drift, where it's sort of, the longer it is inserted, the more it sort of loses accuracy. But its advantage is that it's associated with a less risk of infection and hemorrhage. There are other invasive ICP monitors that can be inserted in the subarachnoid space and the epidural space. But for the subarachnoid space, they are rarely used, again, because of they're largely inaccurate and they also clog easily. And in the epidural space, the inaccuracy largely comes along with damping of the pressure. The dura sort of damps the pressure. Yeah, so with ICP monitoring, again, like I've illustrated, you get an absolute value, but you also get a waveform analysis, and they're largely, the types of waveforms are largely S, C, and B. So the B waveforms and the C waveforms are largely physiologic, and they're associated with changes in either respiratory or cardiac physiology, while the A waveforms are the pathological ones. Again, the amplitude of the waveform is important because it signifies brain compliance. So what are the indications of insertion of an ICP monitor? These are based on the current guidelines. So, and of course, there's a lot of inter-hospital variability, but the indications would be a patient who's considered to have severe brain injury, that is with a GCS, based off the Glasgow Coma scale, with a GCS of around 3 to 18 after resuscitation, with an abnormal brain CT scan. The other indication is a patient with severe traumatic brain injury with a normal CT scan, if the systolic blood pressure is below 90 millimeters of mercury and the edge is below 40. We'll excuse the grammar, I'm dyslexic. Then the other sort of, there's an indication that also goes, the other sort of schools of thought that think you can insert an ICP monitor based off the risk of ICP. So you evaluate a patient and you see that just based off your clinical signs and symptoms, and also your imaging, that this patient is high risk for ICP, that in itself, of course, sort of can lead to a lot of inaccuracies. So the other thing that people are developing, I think by a recent scholar, Ali et al., is some of the prediction tools to sort of predict intracranial hypertension. And some of these are based on imaging, for instance, high Marshall scores or midline shift of more than 5 millimeters. So it has a major criteria and then it has a minor criterion. So it's there are scores that are given, and then based off what they'll get, they'll insert the catheters. So this is an example of an EVD catheter. Again, like I said, it's inserted in the lateral ventricle, and it is then, like all invasive catheters, it has to be leveled and zeroed. So this is leveled at the level of the external auditory meatus. And of course, like I said, it's maintained after you've leveled and zeroed it. You need to maintain the patient at that height of the bed. Otherwise, any changes in height positioning will give you different values. So it's connected again using through a clock to a drainage bag with a pressure gauge. And intermittently, you also connect it to a monitor where you can transduce and get invasive pressures. This pressure gauge should have pressures of up to 100 millimeters of mercury. Yep. So these are the waveforms that I have, the waveform monitoring that I've been talking about. The air waveforms are the pathological waveforms. And basically, you are concerned that, and you will initiate an intervention if you get an ICP value of above 20 millimeters of mercury for more than 15 minutes. Yeah, for more than 15 minutes. For more than 15 minutes. So that means that is considered a an elevated intracranial pressure, and you need to institute an intervention. Like I said, the B and C waves are largely physiologic. The A waves and the amplitudes are telltale signs of decreasing brain compliance, and they basically have to be persistent for more than an hour. So after talking about the invasive monitors, we can also talk about the non-invasive modalities of ICP monitoring. One is, of course, there are CT scans, CT scans, MRIs, and fundoscopies just basically tell you about papilloedema. There's a transcranial Doppler, and this is just basically an ultrasound across major cerebral blood vessels that basically looks at the velocity of blood flow around the major cerebral blood vessels, and is also the interpretation is basically in waves as well. There's also ocular sonography. So ocular sonography basically use an ultrasound on the optic nerve, and it tells you about the sheath diameter. So of course, the bigger the sheath diameter, then that is increased ICP. So average ranges of more than 5 to 6 will tell you about ICP. Then there's optic nerve pressure. That's also done with a tonometer. There's tympanic membrane displacement. The other modalities that basically measure brain oxygen saturation, like the near infrared, or the EEGs that basically look out for seizures, and in other things can also be used to monitor. Largely, these non-invasive modalities have not gone mainstream. Most of them are still, apart from the imaging, the CT scan, MRI, and endoscopy. Most of the other non-invasive modalities are still in the stages of clinical trials. Yeah, and there are no guidelines out. So again, like I said, as we advance, we are sort of going to target more of, right now, most of our monitoring is based on ICP monitoring, but eventually we want to move towards cerebral perfusion pressure monitoring. So again, what management of ICP? I will try to summarize the management of increased intracranial pressure with this diagram, and hopefully I'll do a good job. So of course, the mainstay or the definitive management, or when a patient has ICP, is to get rid of what you think has caused is causing the ICP. If the patient has an epidural hematoma or a subdural hematoma, that means that those things should be are evacuated. But eventually, of course, the thiazotes 1, 2, and 3. So when the starting point for any form of increased intracranial pressure is usually the ABC. D, that's the resuscitation, even before all the other measures are instituted. So, of course, when you evaluate the patient, is the airway patent? If the airway is not patent, that means that that patient is probably going to be hypoxic, which you don't want to happen. So you would want to basically secure the airway, and in securing the airway, you want to avoid circumstances that are going to cause elevated intracranial pressure. So you have to make sure that you have achieved a good anesthetic plane. You give your muscle relaxant, you give a good sedative hypnotic, and an analgesic in the order in which they should be given. However, you should also take note that you should avoid hypotension. Of course, during your intubation, you should avoid things like I said, that increased ICP, coughing on the tube and gagging. That's why you should have a good anesthetic plane. So with breathing, that's clear. You need to make sure the patient is either oxygenated, or if you've inserted your an endotracheal tube, that they're ventilating well, and they're also oxygenating. And then circulation, like as we go ahead, you need to maintain a good mean arterial pressure so that you can maintain a good cerebral perfusion pressure. And that should be in keeping with the patient's comorbidities, like we talked about the hypertensive individuals. And the other thing to note is to avoid drastic variations in blood pressure, because all those can affect the cerebral perfusion pressure. And also, if a patient is hypertensive and the hypertension is due to increased intracranial pressure, then largely you should, the aggressive management of, the main target is not to aggressively manage the hypertension, but to treat the cause of the increased ICP. And if that fails, then you may need to resort, of course, to giving antihypertensives and some sympatholytics, because eventually cerebral perfusion pressures of above 120 can be largely deleterious. Positioning of the patient is important. Remember to keep the head of bed at about 30 degrees and to keep the head in neutral position. When you have an ICP monitor, you're able to notice that any turning of the head on either end will cause a slight raise in the ICP. Also, for patients who may have tracheostomies or ETTs, prevent tight, anything tight, so tight around the neck. And I think in this instance, any central lines are better off inserted in maybe the femoral. You need to control pain and sedate the patient adequately while intubating. We talked about cerebral metabolic rate. So you control things that that will increase the cerebral metabolic rate. So control pain, sedate the patient, control fever, seizures, and of course you need to early imaging of the patient and early neurological consults. So after resuscitation of the patient, if the ICP is still high, you have signs and symptoms of ICP, and there isn't a structural cause, something that you're going to remove immediately, then that means you're largely going to you should insert your ICP monitor, and in tier 1, you should start osmotherapy, which is either hypertonic saline or mannitol. Of course, the difference currently, there isn't, one is not superior to the other. So you should know the doses at which they are given. Usually the changes in ICP will occur within at least 40 minutes for mannitol. You should remember to keep note of your, to monitor the serum osmolarity and keep that below 320. And also monitor the sodium, that you should keep below 150, and also avoid drastic increments in sodium of more than 10 millimeters of mercury. So for tier 1, again, you maintain oxygenation, like we said, with a PaO2 between 80 to 120, and you maintain a PaO2 between 35 to 50. Yes, so I can speak about hyperventilation here. Hyperventilation is a treatment that you institute in severe ICP, and in some cases when the patient is coning. It is a short-term measure. So ideally the patient should not be hyperventilated for more than 2 hours. Remember, they can be, with hyperventilation, there can be cerebrovascular constriction, and this will eventually lead to hypoperfusion. In fact, some people say this measure should not be instituted in the first 24 hours of an injury, because it worsens the incidences of cerebral perfusion. Yeah. So here you can also insert your EVD, like we said, to monitor. And if there are instances of obstructive hydrocephalus, then you will have continuous drainage going on. So CSF diversion and osmotherapy are the mainstay for this tier 1. Then after the measures of tier 1 are refractory, then you move on to 2, which largely combines medical therapy. That means the patient should be they should be sedated so that you can control a cerebral metabolic rate and reduce cerebral blood flow. We do this with benzodiazepines, with barbiturates, and also with propofol. You should also optimize your cerebral perfusion pressure, and you can do this with fluids. Of course, the fluids are largely crystalloids. Avoid hypotonic fluids, and there's currently no benefit of giving colloids, particularly. I know that's one of the things that showed up. Balanced fluid versus normal saline. I think with the hypertonicity of the normal saline, I'd go with normal saline. So the other thing, of course, you need to control paralysis. Remember, any changes in intrathoracic pressures or intra-abdominal pressures affect your ICP. So you need to have good bowel care. If a patient is gagging and coughing on the tube all the time, you may need to sedate them. In patients in trauma who have multiple injuries, maybe if the patient has ARDS at the same time with ICP, you should be cognizant of the fact that your ventilatory parameters, especially the PEEP, will affect your ICP. So normothermia, like one of my colleagues has emphasized before, we should avoid hyperthermia, and we should not really institute hypothermia. The major goal is to keep the patient normothermic. Again, this decreases cerebral metabolic rate. So tier 3, with ICP that is refractory to all the measures above, that is when you will do a decompressive craniectomy, either hemicraniectomy or bifrontal hemicraniectomy for raised ICP. Yeah, and there are some measures like a barbiturate infusion, largely to target burst suppression. Yeah, it's made like a multi-modal approach. The hypothermia, of course, is something that we've gotten rid of. Okay, thank you. That's all I had.
Thank you so much, Dr. Joyce, for that rich presentation. So basically here you have gone through aspects of neuromonitoring as is currently clinical applied, the implications, part of the interpretation of the different neuromonitoring devices and techniques. Of course, maybe at some point you will tell us which ones are feasible or we use occasionally or commonly in our setting. I know you may have already mentioned it, but maybe just highlighting which patients will need placement of a neuromonitor in them may be helpful. So those are some of the few things I would kind of preempt as questions, but I'd like to welcome questions from the rest of the audience. Do we have any questions for Dr. Joyce, people?
Erasmus, I should perhaps wait for the questions from the audience. We could run another poll so that we get that out. Yeah?
Sure. Maybe if I could have Dr. Joyce respond to, oh yeah, she already highlighted there the indications that I was asking for. So yeah, so let's just get the poll questions up and then we return to the discussion.
So I will start with the previous one. Comments on this, Joyce and Erasmus?
I think just based off the pathophysiology of ICP, I would go for a fluid that is a bit hyperosmolar. So for during resuscitation, so that is why based off the so the balanced solutions basically have the same osmolarity as serum, while normal saline is hyperosmolar. So based off that explanation, I'd go for normal saline during resuscitation.
Okay.
Thank you, Dr. Joyce. And technically, I would go for that, but I think the question here is, the answer really is what is most available to you between the balanced solution and normal saline. First of all, when say balanced solution, really, it's a broad term that refers to different types of fluids. Commonly in our setting, when we say balanced fluid, we're talking about ringas lactate, but the other balanced solutions with a higher sodium content and ringas lactate, like Plasma-Lyte, that are also in clinical practice, probably not in our setting right now. But at the end of the day, the idea really is that you want to volume expand, restore perfusion. That probably is far more important than nitpicking the sodium content of the different fluids. Now, when it comes to ringas lactate, of course, it's a constant that the more ringas you give, the higher the higher the drop in maybe serum osmolarity. This has been tested in some trials and really it doesn't appear to be a significant drop in serum osmolarity, probably because the balance is beyond just the chloride alone. There's also that lactate, which might contribute to some of the osmolyte activity later on when it's metabolized to bicarbonate and the like. Maybe the question is, at the end of the day, how much of the solution that you need for resuscitation might be given to the patient to restore perfusion without necessarily overshooting on the volumes that are needed to drop the serum sodium significantly. And perhaps if we remember that we are doing active management of ICP, where you're also using hypertonic saline here and there, maybe the difference between normal saline and ringas lactate in terms of maybe the sodium, serum sodium drop might really not be significant anymore versus the potential changes in acid base and chloremia that might result from using a hyperchloremic fluid like normal saline. So I honestly wouldn't mind using Ringer's lactate in these patients in our setting, or another balanced solution like Plasmalite where it's available. Thank you.
Okay.
But definitely, they want to avoid here is a hypotonic fluid like dextrose.
Yeah. Allow me to perhaps ask our EM physicians who usually start off with the management of these patients. Any comments from Celine and Mary Ellen regarding the fluids? I know sometimes you may run out of the isotonic fluids in casualty. Celine? Okay, maybe we shall wait for them to organize their thoughts. Mary Ellen.
Yes, I was saying I'm new enough to this setting. It's hard to say. I certainly agree that the most important thing is probably getting the perfusion back. We're moving more and more in general to balanced solutions, but it's hard to say. In a head injury, I might still reach for normal. I might still reach for normal saline.
Yeah.
What do you do?
I'll probably grab normal saline as instinct. And then think about the complications a little later, at least for the resuscitation. I think most of us will probably grab the higher sodium content at the initial resuscitation. Yeah. So I think let's go into the next question, next poll. So the next poll is still about fluids, and this is going to be what triggers you use for hyperosmolar therapies. So what triggers your use of hyperosmolar therapies? And these are the options: TBI with stress epilepticus, diffuse axonal injury, subarachnoid hemorrhage, contusion with midline shift. So you can submit your answers as soon as you are ready. We shall have about a minute to close the poll. We have, I think, 2 more questions, and then the polling will end. Okay, about 5 seconds left, and then the polling ends. All right, about 53% of the participants have responded, and this is the result. So over 60% would select to use hyperosmolar therapies in contusion with midline shift. So I'll invite comments from Joyce and Erasmus.
Dr. Erasmus, I pass this on to you.
All right. For hypersmaller therapy, the idea really is to try to shrink the brain quickly, reduce the contents of that box, and ICP and perfusion improves. So a patient who is having a contusion with a midline shift is definitely at an increased pressure. The rest, particularly subarachnoid hemorrhage, may not necessarily have that kind of ICP that may respond to this, but needs to be considered in as a special case. Most diffuse axonal injury will not really lead to raised ICP unless there's some other adjoining injury they might be having. So generally not the kind of case where you want to be throwing in a lot of hyperosmolar therapies, but definitely you want to avoid a drop in sodium from normal overall for all patients with TBI. A patient with status epilepticus may be having so many causes of in which case you want to consider again isolation, but out of the 4 options, the final option definitely necessitates hypersmolar therapy.
Okay, so next polling question is, how do you administer 3% saline for osmotherapy? Do you give it as a bolus? Do you give it as a slow infusion? Or do you give it either as a bolus or slow infusion, but with that P-clamp? We shall have about a minute again to respond to that. Feel free to just select any option and then we can discuss it. We have nearly a third of the attendees have responded so far, which is a good sample size to have. We have about 10 seconds to the end of the poll, so you should be able to submit your answer in the next 5 seconds.
Hello.
So I will end the poll now. All right, and then these are the results. So a majority, over 80%, would give it as a slow infusion. Over to you, Dr. Erasmus.
Yeah, thanks. Now for this particular one, the idea is that you want to jack up this serum osmolarity, the tonicity of blood, so that it can suck out that blood, that fluid that has extravasated into the intracranial cavity. So if you give it as a slow infusion, you're allowing for equilibration of interstitial, vascular components, and you may not achieve the osmotic effect you want. So it's recommended that you go with a bolus dosing of these therapies instead.
Okay. All right. And then the final question is about what Isaiah asked. And this is about saxamethonium. Should saxamethonium be used for intubation in patients with raised ICP? We shall have about a minute still to answer that, and then we shall have it for discussion. So saxamethonium causes fasciculations, like Isaiah mentioned, and it's been known to increase intracranial pressure. But perhaps the question is that actually clinically significant? Is there anything that we can do to avoid the fasciculations? And I think those are some of the discussion points that we shall have. So we have more than 40% people who have responded, 5 seconds to the end of the poll. So I will end the poll in 3, 2, 1. Okay, so these are the results. A majority, more than 60% have said no. So I will hand over to Dr. Erasmus to make comments on that and also give any final submissions and have this session brought to an end. Thank you.
Thank you, Dr. Cornelius, and thanks everyone who participated in the poll. So for this particular one, the real question on the table is the balance between achieving intubating conditions to avert the risk that hypoxemia, prolonged hypoxemia or hypercapnia due to ventilatory oxygenation failure poses on the brain that's already injured, versus the side effects that SACS might bring in. So we definitely know that SACS might increase, ICP from all the makers we talked about, but currently it's probably the best muscle relaxant to provide the intubating conditions you need to quickly secure the airway and start oxygenating and ventilating the patient. So that other value it has by far trounces any potential risk that it might have, and therefore SACS should probably be used in disintubation as long as not contraindicated. Of course, now in the market we have rocuronium, which when dosed properly probably achieves intubating conditions about a similar time or slightly or very close a time as a good dose of saxamethonium might do, without necessarily causing the similar effects that that on ICP that SACS does. And maybe you might switch in that direction But overall, there is no contraindication to using SACs in patients in whom it's appropriate for intubation. Similarly, previously we used to fear ketamine for similar reasons, but we found that while it has got the hemodynamic effect of raising blood pressure, it seems to be one of the most potent drugs in lowering kind of improving cerebral perfusion, as well as lowering brain activity, especially patients who are having seizures. In fact, it is one of our go-to drugs in the end when a patient is refractory to seizures, for example. So ultimately, no reason to fear SACs, no reason to fear ketamine either. That's my comment on that. Let me just see the chat if there are any. Okay, fine. Dr. Cornelius is giving some response there. So do we have any quick questions on Dr. Kalunji's talk? All right, maybe just one more comment about KET is that, ketamine is quite readily available. It's quite hemodynamically good. These are patients who cannot sustain a drop in blood pressure, which will probably reduce cerebral perfusion pressure and risk cerebral ischemia. Of course, in other settings, drugs like etomidate exist. Worries about adrenal suppression are probably not to be pushed so much for a single dose used for intubation. But in our setting, ketamine probably is our poor man's etomidate, which kind of does not drop the blood pressures. If anything, it might increase them a bit, which might sustain cerebral perfusion in our patients, compared to the other drugs that are available in the market, like thiopental, things like propofol, which may dump your BPs during intubation if given at intubating doses. So you have to really be, I think you should probably be promoting the use of ketamine in this case. How you use it to avoid its side effects versus its benefit, that's a conversion for another day. So at this point, with no questions coming in for Dr. Dr. Agaba is asking us to comment on the triggers for osmotherapy, prophylactic osmotherapy, and targets of osmotherapy. Perhaps I would like to just invite Dr. Agaba over the next minute or two to just comment on this. Could you, Dr. Agaba, go ahead? Peter Agaba, kindly comment on aspects you asked about on osmotherapy, its triggers, prophylaxis, and endpoints.
Noisy place.
All right, perhaps you could just be typing your responses there in a bit. But I think the questions you've asked are quite important in that there are times when I've seen patients who are on osmotherapy, up to day 7, the guy is coming out of, he's already probably waking up, but he's still continuing to receive osmotherapy as a routine prescription. Dr. Gaba, kindly continue as I continue making some of the comments. Can give us some of your ideas in typing. This session has been on traumatic brain injury. Next Friday, we shall be switching up the conversation to another topic. We shall be discussing renal medicine, basically aspects to with acute kidney injury in the ICU. Kindly come back in droves, and the more important, read around the topic and then come around with questions. We shall try to find other collaborating colleagues who will participate and provide us their expert opinion as we build a multidisciplinary approach to critical care. For those who are interested in being presenters on these days, please reach out to me inbox, and I will schedule you. In the meantime, Dr. Gaba, are you set? Okay. So perhaps I can push this to everybody. Okay. So basically, you would like to probably perform osmotherapy in patients who are high risk for deterioration or already show signs of severe brain damage or progressive brain damage. As there are pupillary changes, patients' GCS is dropping quite rapidly or is already quite low, and there is evidence radiologically of disease that's highly associated with raised ICP or is worsening if you're able to serial imaging. But definitely at the end of the day, when do you stop? So you have to again monitor the same endpoints. Also, if you're using hypertonic saline, you're really watching for that osmolarity, looking at the sodium targets. Looks like above 160 millimeters of mercury, you probably, 160 millimoles per liter of sodium, you probably are not getting any more benefit from adding sodium to the patient. In a patient who is quite significant ICP, and should be considering other options. Similarly, you probably don't want to be managing a patient with ICP with osmotherapy alone. You probably need to be using a concerted approach beyond just osmotherapy. For example, metabolic optimization for patients who are hypoxemic or it's not perfusing and the like, so that you reach the target of improving brain perfusion, brain function quite quickly. I don't know if I might have, I've seen on the chat, Dr. Gaba has talked about the triggers being clinical changes or radiological changes, and targets should ideally be improvement clinically. Prophylactic osmotherapy, Dr. Gaba. Dr. Cornelius, regarding the targets to use, I guess the challenge is now setting frequently different areas patients go to might intervene differently, also depending on the resource they have. So many patients who come and receive hypertonic saline therapies might actually also be might have received, say, mannitol somewhere. So I think in that scenario, definitely serum osmolarity would be quite a more useful test. Serum sodium, the idea is that, it gives you a bare minimum of what the serum osmolarity is. And definitely, if you're at 160 millimoles per liter, perhaps the patient's osmolarity somewhere at least 320, beyond which you're not getting any more benefit really of hyposmolar therapies anymore for your raised ICP. But yeah, I think if you have the resource, maybe osmolarity would be the best monitor to use. But clinical picture always, the numbers are useful, but the clinical picture is a key thing. All right, people, I've kept here for long, and we've done a good job and hopefully justice to the topic of traumatic brain injury. And I hope that the learning points for students, for practitioners, and aside from shaping your interest in the care of traumatically brain injured patients, I hope this also brings up a number of research areas that people might want to cover in a number of studies that they want to do. I would like to disband the group now, and thank you so much for your attendance. Let's see you on Friday next week. Thank you. Bye-bye. Let's just say I'm a lawyer right now.